Good afternoon, good evening to all of you. Thank you for joining us at this event, Science First, Ask the Author. As you know, we're very happy to host this kind of event. It is somehow the essence of ZAGA Centers to meet around the science and develop further the clinical expertise and knowledge and publish all together. I'd like to begin with the map of the updated network. 3 years we are live and working. The network has been growing a lot, especially during the last year that has been quite complicated for all of us. And we reached a milestone of 50 centers, 50 members, 50 exclusive centers in their area dedicated to zygomatic implant rehabilitation. So congratulations for the whole group to grow this fast, to be collaborative, and to show you a bit of what it means from the inside. I'd like to share 3 initiatives that are ongoing now. The first one is the ZAGA Centers podcast. This is bite-sized interviews, 15 to 20 minutes interviews of the members of the networks. We'll also have special guests very soon. So far, we have 2 episodes published. The first one from Professor Jamal Ucha, and the second one from Dr. Roger Johnson-James, and from respectively ZAGA Center Manchester, ICE Hospital, and Implant Fracture from Chennai, India. We publish every 2 weeks, so feel free to subscribe to all of it to avoid missing an episode or missing a key guest that you would like to hear about. Second initiative that we're launching, again focusing on science, is the ZAGA Study Club. This is something we are very proud of. We have thought a lot about it, how to make it work, how to launch it. We finally launched it this week on 3 different topics so far. So the objective is to progress in these. Topic number 1 is all about the quad zygoma, including biomechanics, ideal implant positioning, risks, and processes. Second topic that has been launched this week is related to the skin fistula complication, its etiology, and the treatment options. This is something we've seen quite a lot of questions about it, so we'd like to treat it in a scientific way and find solutions to prevent it and to treat it successfully. And finally, the last topic is focusing on the prevention of soft tissue complications, and this includes obviously the use of the Bichar fat pad, scarf graft, plasma, and other techniques. So the whole objective is to protocolize and scientifically look into it, see what works, what does not, what may work, and what may not work, everything in a scientific fashion. Third initiative is this event, Science First, where you have the opportunity to first listen to authors of peer-reviewed publication that we will introduce right after this introduction, and ask them, hey, what about that study? What did you see in this specific topic? What are your conclusions? Did you have any complications? And any question that may come to your mind during the presentation. So one way to send the question is via the YouTube Live. Probably while you're watching this event now, you have a chat either below or on the right side. Just write your question there, and I will share them, either all of them or a selection of them with the speaker talk. Now, before jumping into the clinical aspects and welcoming Dr. Aparicio with me to introduce the speakers, I would like to answer a few questions. The most common questions we have after this kind of event. First one, how can I certify as a ZAGA center? Second one, where can I get information about the educational course, the ZAGA course? Third one, this is something we like to hear a lot. I want to listen to the podcast. Yes. And the fourth one, I want to be part of the study club. Well, most of the answers are all on our website, where you can also reach out to us if you want to develop more on one of these topics, except the study club that is only reserved for members, for ZAGA centers, Either you can join us or just wait to see the results via podcast and webinars in the future. So now let's get straight to the point. You took a little of time to be here today. We'll go straight to the speaker introduction. Dr. Carlos Aparicio, welcome to be live on the feed with us. You are the founder of ZAGA Centers. You are, I think, the friend of 100% of all the participants. I think they all know you. You probably know most of them. I want to think you remember all of them. I don't know if that's true, but I think you have four very passionate, interesting speakers to introduce to us today.
Thank you, David, for this nice introduction. I believe the most important part is I'm mostly fan of everyone being here, so that's the important part. It's very privilege to be here today, and my first word should be thanks to the people in the other side of the screen, for sure, because without of you, we wouldn't be here. But thanks for the group of outstanding speakers we have today with us. So it's really, for me, a privilege, but also a challenge to be to share this podium with this, as I said, outstanding group of authors and researchers and experienced surgeons in this kind of tricky rehabilitation. So the first speaker we will have today with us is Chow. Dr. Chow. Dr. Chow, he will explain us about sinus reactions. He will address very, very interesting questions about how much about the type of sinus reaction we may expect after separating the sinus lining or after grafting the sinus. So I think there will be very, very interesting questions after his lecture. I wonder, yeah, I have a lot of questions for you, James, after your lecture, so I don't want to disclose it now. So I'm really, really waiting for the end of your lecture. After Dr. Chow, we will have the pleasure to listen to my friend Lesley David from Toronto. She will address the whole structure of the quad intervention, the quadruple zygomatic implant installation or quad procedure. And she is going to address it from the beginning. She will make a quick review of the evolution of the surgical technique, and she also will address the surgical requirements, the planification, the topics that we should take into account previous to go to this kind of surgery. Of course, she will speak about results and almost everything. And most important maybe is she is going to explain us what we should look at in order to prevent complications, and some of them how we will be able to treat or to escape from. So also it's going to be a so important lecture, and I think I'm very happy to have you with us also today, because this type of rehabilitation is referring to the most atrophic maxilla, so is the most difficult one. And in the way you are going to explain it, it looks like it is easy, but as you mentioned in your lecture, this we should, I would say, love yourselves and start for the double zygoma, more, if I can say that, easy cases, and then wait for having passed through over this learning curve in order to address this quadruple zygoma with some experience on the zygomatic implants.
Dr. Aparicio, I think we have an echo problem with the sound. I see the participant from YouTube say we have echo. So let's give us 5 little minutes so we can look into it. And André Shakima tells us now it's perfect. Can someone else confirm we do not have any echo? Better, Victor de la Paz says it's better. Okay, I think we can go on. Very good.
Thank you, David. And this side was okay, so but thank you again. So we will end up with Dr. Rubén Davó, which I would like to, I think David is going to...
Carlos, excuse me, it is bad again. Andre and Sakima told us they have echo.
So is from here, maybe? So I'm going to say like stupid things in order to allow our technical equipment to fix this echo problem.
Dr. Aparicio, can you tell us how you came to dentistry while we take the sound, do the sound check? In no less than 10 minutes, please.
Okay, I will. Thank you, David, again. So I will use this few minutes for fixing this in order, and I will, I can tell you how I came into the zygomatic field. It was because of a patient. His name is Iñaki. Ignacio was a young man at that time. He was like 18 years old when he came into our office. At that time, I have a partner. His name is Jordi Olive. So we used to have an office between to share the office. So we have like few experience on not in zygomatic implants, but in current implants. So when Ignacio came into us, he had to lose his premaxilla because of a iatrogenic problem. So he received a badly performed maxillofacial surgery in order to reposition his premaxilla. And it looks like during the surgery, the surgeon made like a strong movement, and the vascular, the irrigation was cut it. So at the end, the surgeon replaced, the surgeon put the premaxilla in the ideal position. So he thought that maybe vessels could jump into the void and revascularize the premaxilla. I think that of course didn't happen. So in 3 weeks, Ignacio noticed that the teeth were moving, and then the week 4.
The sound is back, but we'd like to hear the end of the
story.
Case.
Thank you. So after 4 weeks, a couple of teeth came out with the surrounding bone. So 1 week later, the whole the anterior maxilla came down. So Ignacio ended up with a big hole of about 2 centimeters from the nose to the oral cavity. He lose from premolar to premolar at 18 years old, I told you. So we asked P.I. Braunemann what we can do with this. So we went there, and it was, Ignacio has a lot of luck because at that time it was Eugene Keller from the Mayo Clinic spending a sabbatic year with P.I. Braunemann. So P.I. Braunemann made in his office 2 long implants with a machine like that. Himself, he prepared 2 long implants, and Eugene Keller from the Mayo closed the soft tissue. So closed the oronasal communication, and PI took some bone from the hip and stabilized the bone in the zygomatic bone with those 2 implants. So this was our first contact with zygomatic implants, and this was around 1987 years. So at the end of the 80s. So after this, we had to wait like 10 more years to have zygomatic implants in a standardized way. So this is why I was waiting for this procedure, and this is why or how I met Professor Chantal Malaves, who was also my first teacher, and I'm very grateful with her also. He came for a weekend in Barcelona, and in a weekend we did 3 patients that I was waiting for. for. So I think I may start with the last participant,
Yes,
David.
you can.
Okay.
Yes.
Okay, thank you for this additional explanation of how I came into the zygomatic implants. So I was going to thank Dr. Davo for being with us today, because he is going to introduce us what I think is the most a part of the systematic review. This is the type of study that has more scientific interest. It's a randomized clinical trial. And in this randomized clinical trial, he will compare 2 groups of patients. I think they are on the 3rd year of comparison. One group is an immediate loaded patient on zygomatic implants, and the other group of patients are patients that receive conventional implant treatment on grafted atrophic maxilla. So I think it's also going to be a very, very interesting lecture, and you will see how we are changing our mentality today. We are changing our gold standard for treating those kind of atrophic maxillas, those kind of how we are moving for a very, very long treatment, for a treatment with a lot of morbidity, to a very quick and predictable treatment. Again, thanks to all of you for being so generous, sharing your knowledge with us. So I let you, David, to introduce formally the first speaker, and let's go on this good day and this wonderful day, I would say.
Thank you, Carlos, Dr. Aparicio. Now I feel at the same time very proud and honored and tiny to introduce Dr. Chow. He belongs to the first group of locally trained specialists in oral maxillofacial surgery in Hong Kong. He is a zygomatic implant expert. I think you don't need much of an introduction to our audience today. You're also the head of the Dental Implant and Maxillofacial Center at Hong Kong, certified as ZAGA Center Hong Kong, and you frequently participate as a key opinion leader with several companies. You're an honorary associate professor at the Hong Kong University and Shanghai Jiao University. And above all, you're an excellent educator, and we're very happy to have a session counting on your knowledge, experience today on sinus grafting and zygomatic implants, their reaction. So please, Dr. Chow, it's all on you now, and then we'll join for the Q&A session at the end of this plenary talk.
Hello, dear colleagues. Sinus pathology and sinusitis are important issues for consideration in patients receiving zygomatic implant treatment. In particular, maxillary sinusitis can be troublesome and difficult to manage. In this systematic review published in 2016, we can see the long-term survival rate of zygomatic implants was actually very high, up to 95.21% after almost 12 years. However, in this systematic review, the author also stated that there are a certain incidence level of maxillary sinusitis and other soft tissue problem. And for maxillary sinusitis, we see up to 2.4% of patients may develop this complication after receiving zygomatic implant treatment. And it is believed one of the main reasons for this patient to develop maxillary sinusitis is because of the development of oral-enteral communications. Therefore, it is always a vigorous discussions regarding the use of extrasinus versus intrasinus placement in recent years when we are treating patients with zygomatic implant. This is a study specifically look into these situations, try to compare between extrasinus and intrasinus placement and see what are the incidence of sinus reaction. The authors compare their own experience with another 3 study. Basically, this study concluded extrasinus placement is associated with a lower incidence of postoperative clinical and radiological sinus reaction. In 2010, we published this article, try to develop a technique to always keep the zygomatic implants external to the maxillary sinus. In this study, 16 consecutive patients were included. During the investigation period from 6 months up to 24 months, all these patients are free of clinical signs and symptoms of maxillary sinusitis. That means the short-term result with sinus lift being performed before zygomatic implant placements seems to be beneficial. However, we are more interested to note what are the long-term outcomes among this group of patients. Recently, we have recalled this group of patients for an examination. Unfortunately, 4 of these 16 patients dropped out. For the remaining 12 patients, these are the combined CT taken during the recent review, with at least 10 years later, with at least 10 years after the initial zygomatic implant treatment. And it seems in these 10 cases, the combined CT images confirm there's low pathology in the maxillary sinus. We don't see any sinus membrane thickening, and we don't see any obstruction between the maxillary sinus and the nasal cavity. Unfortunately, there are 2 patients among this initial group of patients did present with sinus problems. One patient actually developed maxillary sinusitis on the left side, and the other patients developed sinus membrane thickening without sinusitis. So that means 1 out of these 12 patients returned for 10-year review presented with sinusitis, and another 1 out of the 12 cases presented with sinus membrane thickening. Together, we see a significant proportion of cases develop clinical symptoms or radiological sign of sinus pathology. So we can conclude simply keeping the zygomatic implant external to the maxillary sinus does not completely eliminate the risk of sinus pathology after zygomatic implant treatment. However, say in this case, it seems oral-enteral communications is related to the sinusitis, but somehow oral-enteral communications did not account for all cases of sinusitis, because we see the OAC develop on both sides, but only the left side actually developed sinusitis. If we go back to the preoperative combined CT of this patient, we can see at the beginning, before treatment, this patient already present with some sinus problem on the left side. We see the ostium was blocked, and also there are signs of sinus membrane thickening. So it is not fully understand why in some patients after zygomatic implant treatment, they develop sinusitis, whereas the others did not. Even though OAC is maybe a causative causes, but it doesn't account for every cases presenting with sinusitis. So that's why people may ask this question: if simply keeping the zygomatic implant external to the maxillary sinus is not sufficient to eliminate completely maxillary sinusitis after zygomatic implant placement, then is grafting after sinus lift a beneficial? Here is a study published in 2011, similar to our previous report. This group of colleagues in Belgium, they perform extended sinus lift before zygomatic implant placement, but they always graft the sinus before and after the zygomatic implant placement. In my practice, we have been doing grafting after sinus lift since 2011. Let's see a recent cases to illustrate the technique. This is an elderly lady presented with terminal dentition. And cone CT show that the posterior maxilla has limited bone height. Computer panning show that these patients present with Saga type 0 on both sides. During surgery, after osseous reduction, anterior maxillary implant were placed. Then we perform lateral window on the maxillary wall. And after that, we lift the sinus membrane with the bone wall attached. Then we prepare the starting point for the zygomatic implant and then the end point. Before placement of the zygomatic implant, we first graft the sinus bore using xenograft. And then we insert the Saga round zygomatic implant. Similarly, we perform the same procedure on the other side. And before we close the wound for making impressions, we also graft the coronal part of the Saga round zygomatic implant. And this was the clinical picture taken after the delivery of the provisional prosthesis for immediacy. And an OPG was taken after the prosthesis was delivered. By performing grafting after sinus lift, we believe there are biological and biomechanical advantage. Not only we create a robust bone barrier separating the sinus cavity to the oral cavity, according to the finite element analysis, we understand grafting the sinus bore will increase alveolar bone support at the coronal part of the zygomatic implant, and this is beneficial for low distribution under function. Here is another case with grafting after sinus lift. And in fact, in all of our patients receiving grafting after sinus lift before placement of zygomatic implant, we see similar good result. And in this group of patients, we don't see sinus membrane thickening and we don't see the blockage of the ostium. we look at our own data from patients treated between 2004 to 2014. And you can see comparing zygomatic implant placement with intrasinus path and zygomatic implant placement with just sinus lifting, and also sinus lifting with grafting. And we see there is significant difference in terms of patient developing sinusitis afterward. Of course, we don't believe simply by doing sinus lifting and grafting will solve all the problem related to all the potential complications related to zygomatic implant placement. For example, by performing grafting, there is a chance for us to see graft infection, graft failure, and still, even with grafting and sinus lift, it is possible to see patients presented with buccal dehiscence surrounding the coronal part of the zygomatic implant, and also patients is still susceptible to develop peri-implantitis under certain situations. And the other important issue for consideration is to develop a more robust system to assess the success of zygomatic implant treatment. And Dr. Aparicio actually proposed the ORIS criteria of success. And this is a recent publication by Dr. Aparicio and Dr. Albrechtsen. So to conclude, extra sinus placement is recommended for zygomatic implants. Extra sinus placement does not eliminate the risk of maxillary sinusitis completely. Lateral sinus lift with grafting may be beneficial in Saga 0 and Saga 1 situation, but further investigation is necessary to draw conclusion. And most importantly, a better way to evaluate the treatment outcomes in zygomatic implant treatment is necessary. Thank you for your kind attention.
Thank you, Dr. Chow, for this review of 3 to 4 publications. And let's see if we have a few questions from the YouTube live chat. But one question that came to my mind straight away, what is your current protocol clinically? Do you graft? Do you graft before and after? Do you graft in certain cases and in some others you do not?
Thank you for the questions, David. Actually, nowadays, when I plan zygomatic implant cases, I will look at the position of the implant, whether it is extra sinus or intrasinus. For example, if we are talking about Saga type 0 and type 1, when we expected to take an intrasinus path, then usually I will perform the sinus lift before implant osteotomy. And in those cases, nowadays, I always graft because my early experience with just doing the sinus lift to keep the implant external to the maxillary sinus, doesn't work in every cases. When we talk about elimination or reduce the risk of maxillary sinusitis, as I shown in my presentation. So this is my standard protocol nowadays. If I come across patient with Saga type 0 and Saga type 1, especially when the residual bone remaining under the sinus wall is very limited, then I prefer to do the sinus lift and grafting.
Okay, thank you. Just let me pause 1 second. I think we have echo again. We have again a sound problem, what I see on the chat. They say it's back. Okay. I'd like to make the most of the top speakers that we have today and ask if any of the other speakers have a question for Professor Chow.
So
Hi,
I
Lesley.
think we have two questions at the same time. Please, Lesley, go forward.
so I just wanted to confirm that, is there a minimum amount? I mean, obviously we're dealing with with a zygoma situation, whereby there's not that much residual bone, and that's why we're using a Zygoma implant as the indication rather than doing a tilted implant. But sometimes, as you know, we do have some bone in the area where we're placing that zygomatic implant. So do you have sort of a criteria whereby if there's 2 millimeters of bone or 0 millimeters or 4 millimeters, then I'm going to do a sinus lift? Or do you routinely do a sinus lift regardless of the amount of residual bone at the crest?
Thank you for the question, Dr. David. As I said, if it is a case of Saga 0 and Saga 1, then usually I consider doing the sinus lift. But whether I want to graft or not, you see my initial cases, I did not graft. But because, during the follow-up, we see actually there's two possibilities. In certain patients, actually we see de novo bone formation around the implant at the sinus 4. It doesn't happen in every patient with sinus lift, and also even it doesn't happen in the same extent. So if you ask me what is my criteria nowadays to decide whether I put graft or not after the sinus lift, then my experience is most of the time when I'm performing zygomatic implant placement, my patient, they seldom have more than 2 millimeters of bone left at the entrance. Especially if you look at my cases, I like to place the implant actually further back. And it actually put me in a situation that very often I'm usually located the implant at an area actually with the less amount of bone. But I believe if I can place an implant more posteriorly, biomechanically, it's more favorable, and I can handle the situation by doing sinus lift and grafting. So that's why this is what I'm doing nowadays.
Thank you.
Professor Chow, I have two questions from our participants. The first one from Dr. Croatia. Do you have, how much time do you wait after sinus grafting to place the zygomatic implants? And the second question from Ed Liu is, do you have data to show difference of bone grafting results on smooth versus rough zygo implants?
When I do sinus lift, actually, I'm doing it simultaneously with zygomatic implant placement. What I mean is I will first perform the sinus lift before I carry out the implant osteotomy. So that means in Saga type 0, type 1 patient, I open up the sinus, I lift the membrane together with the bony wall, and then I conduct the implant osteotomy, make sure that I keep the implant external to the maxillary sinus. And before I insert the implant, I will graft the sinus 4 first, just like the case I show in my presentation. Regarding the types of graft, actually, at the beginning, when we start doing grafting, we try different material, including the bone morphogenetic protein and also different bone substitute. But I have to say, nowadays, I only use xenograft. But of course, I mean, you can decide whether you want to mix the xenograft with, say, platelet-rich fibrin or tolerance bone. But for zygomatic implant cases, I only use xenograft 100%. I didn't add another component.
Okay,
Talking about the
the second part to the question is if you see different data depending on the type of surface you use, if it's rough or if it's smooth.
When I start doing the sinus lift, actually, I was at the time when we start having the rough surface implant, the Tyolite. Okay, so basically, most of these cases with sinus lift and grafting, I'm using rough surface zygomatic implant. And of course, now, I mean, we have the Saga round and the Saga flat implant, which have machine surface instead of rough surface. And I'm at the beginning of using the new design implant. So I still have to wait to see. But personally, I think it is reasonable to use the machine surface instead of using the rough surface, especially if I'm working on Saga type 2 up to type 4, because that means part of my implant will be exposed outside the bone and covered by soft tissue. And I think those cases, machine surface seems to be more reasonable compared to rough. Doing intrasinus placement, whether I have the sinus lift or not, then of course the implant is not exposed to the buccal soft tissue. Then I'm not sure whether we'll really see the difference. But currently, I know our colleagues in the Saga Centers, some of them are looking at the sinus membrane reaction to machine surface as compared to rough surface. I'm interested to see the result, but very likely, I expect to see something similar to what P.I. Brahma found at the beginning. When the machine surface is exposed inside the sinus, usually we don't expect to see any inflammatory reaction arising because of this implant surface exposure.
Okay, thank you. I think it answered our two questions. Do Dr. Aparicio, Dr. Davo have more questions for Professor Chow?
Yes. Hello, James. I would like to ask you, which are the criteria you use to define a sinus problem? You know, because I feel, and you know, after my presentation, I comment on that there is a confusion on this terminology. You know, if, for instance, if you find sinus is occupied, it's not totally clear. You say it's a sinusitis. Sometimes I have referrals and they send to me the patient just with the face swollen, and they say, no, he's a sinus problem. So I think, I don't know if you agree with me, but it is very, very confusing even today after many years of using that. And I have another question, but I don't remember. So please go on.
Thank you. Thank you, Ruben. I think that I fully agree with you because nowadays we have the combined CT, right? But when we first start doing zygomatic implants, we didn't do CT or combined CT on every cases. But nowadays this is a standard for diagnosis and follow-up. But even we have combined CT, it doesn't mean every time we see our patient, we will send the patient for the combined CT examination. Usually we will do it on certain interval. And if we come to the diagnosis of maxillary sinusitis, the first thing, of course, is the clinical sign and symptom. If the patient presented with pain, swelling, or foul smelling from the nose, or with nose discharge then of course, we will start thinking whether the patient is suffering from some sinus problem. Then the second thing, of course, is radiological confirmation. And at least we will look at whether there is a membrane thickening inside the sinus, and also whether the osteomeatal complex, whether it is obstruct or not. And those are important radiological features we have to looking for when we are performing the combined CT examination. So you see my presentation for those long-term follow-ups. We now actually relying on the combined CT to look at the internal status of the maxillary sinus. I think this is a very useful tool for us to assess the sinus status. But as I said, when patients first come to us, the clinical sign and symptom is the first thing we notice, if whether the patient is having sinus infection.
Okay, I think Dr. Aparicio, if you can unmute your microphone. You're still on mute.
I can hear you, Carlos.
All these criteria following the question of the so this means that you are having some radiological signs to judge. But I will, if you allow me, I will add something. That is, we should not look at the post-operative CCT, but we have to compare the previous with the post, meaning that sometimes it happened to us that we look just to the post-operative CCT, and then maybe we find some inflammation. But when you go back to the pre-operative, the inflammation was already there. So sometimes you find out that this inflammation or this cyst was already previous to the surgery. So our recommendation is to modify the Lund-Mackay criteria, radiological criteria, and establish a comparison between the previous and the post-operative. So this gives you more accuracy in your classifier of the success or the failure of these scenarios. But that was my comment. And my question is, you said something that is very interesting. I understood that you were not able to correlate any communication with the sinusitis. So, do you think that this non-correlation between fistula, which is at the end is a fistula, or antral fistula with sinusitis, can be related with the soft tissue sealing? Do you think this can be correlated? So, I mean, that if we are able to maintain this soft tissue sealing around the implant, maybe we can escape from this sinusitis, although there is a fistula.
Thank you very much, Carlos, for the question. Actually, I think it is multifactorial, I have to say. For example, the case I show in the presentation, actually, the patient present with oral enteral communication on both sides. But on the right side, we only see membrane thickening. But on the other side, there's a complete opacity, I mean, consistent with sinusitis. So I refer back to the pre-op combined CT. And on the pre-op combined CT, we can see the patient actually have an obstructed osteomeatal complex on the left side. So this is one example showing that with the OAC, it doesn't always lead to sinusitis. It is also affected by the, whether the sinus is functioning normally or not. If the osteomeatal complex is patent, then this patient may not develop sinusitis. This is speculation. I'm not saying that I have enough data to prove that. But on the other hand, I actually come across cases well before I start doing Sinus Lift, because I also start doing zygomatic implant quite a while ago. And on some cases, I noticed that if the patient have oral-enteral communication on both sides, but only one side develop sinusitis. Actually, it's quite interesting because sinusitis in zygomatic implant cases, very often they are unilateral instead of bilateral, right? And those cases, I agree with you, it is more related to the integrity of the mucosal seal. Even there is an OAC, if the mucosal seal is still intact, then unlikely the patient will develop sinusitis. But I notice in some patients, if I don't get enough restorative space, when the framework is not robust enough on, say, one side compared to the other side, then it is that side with a thinner framework, with more fracture during function, may predispose the patients to sinusitis. That means if we have mucosal seal only, if the framework under function have more fracture, then it is likely to see opening of the mucosal seal. This is also a speculation because I don't have enough patients to prove that, but this is a clinical observation. Explaining why in some patients, they have sinusitis only on one side, but there are evidence of oral-enteral communication on both sides after zygomatic implant treatment. So I think it is multifactorial. Part of the reason is related to the biomechanics, and part of the reason is related to the physiology of the maxillary sinus. And I don't think we have enough information to draw solid conclusion why patient develop sinusitis after zygomatic implant treatment, and why in some patient it happens and why not in the others, or why on the same patient one side have the problem and the other side no. So it is an area I think we can look into it closely. And I think with the Saga Center, we have a collaboration with a global network. I'm optimistic we can have enough data in the futures to really address on those important issues when we are treating zygomatic implant patients.
Thank you.
I will note this as a topic of the study club, finding the source of sinusitis when using zygomatic implants. That's a great challenge to work on. And so I'd like to thank you, Professor Chow, for being there for the knowledge that you shared. We'll meet again at the end of the event all together to discuss the conclusions. And now I'd like to move on to the next speaker, Dr. Lesley David. I have 3 pages of your curriculum, Dr. David, so I will try to summarize it the best I can. But I think the main point is that you're oral and maxillofacial surgeon, graduate of Toronto, and you're the lead oral and maxillofacial surgeon at Implant Surgical Care, Toronto. You're an international speaker. You publish quite a lot, impact articles. And you're here with us, taking the time to disseminate what you learn, what you research on. So please, we'll be listening to you for a bit more than 15 minutes now, and then we'll join you again for the Q&A live. Again, if you have questions, please share via the YouTube live chat.
I'm so delighted to participate in the ZAGA webinar. I'm really honored to be amongst the authors today. Thank you so much, Dr. Aparicio, for inviting me to speak. You've been a mentor, a colleague, a friend over the years, and it's really amazing to be a part of this ZAGA community or ZAGA family, whose goal is really to collaborate, share ideas, learn, and really be the best possible surgeons we can be for ourselves and our patients day in and day out. Thank you also to Dr. Chantal Malaves, who's on the ZAGA Council, without whom I really would not be here today. Because of Chantal and her generosity, many years ago in 2004, she invited me into her operating room and taught me how to place zygomatic implants. And she made it look so easy, it was unbelievable. So much so that in November of 2004, I treated my first patient with the quad zygoma technique. So thank you, Chantal, for that wonderful opportunity. Last but not least, I also want to thank Dr. Ruben Davo, again, colleague, friend, mentor, the co-author of this article, for his efforts and inspiration over the years. This is really presented on behalf of Ruben and myself. This article was published in 2019 in the Oral and Maxillofacial Surgery Clinics of North America, the Quad Zygoma Technique and Realities. And it's really a review paper or a review article. So I'm going to review the review article today with you all. So the quad zygoma is really a solution for patients who are completely edentulous in the maxilla, who have severe bone loss, so ZAGA 3 or ZAGA 4. There's no bone in the anterior maxilla, no bone in the posterior maxilla, and unless these patients were grafted, you could not place implants. So this allows for the placement of 4 zygomatic implants, 1 anteriorly, 1 posteriorly, bilateral, to rehabilitate patients. So it's used as the first line of treatment and often also used in patients who have been previously grafted to reconstruct the maxilla, and unfortunately the implants have failed. As we all know, bone augmentation procedures carry with it a longer treatment time and morbidity, and this solution is really a graftless solution with less morbidity, very high success rates, and shortens the treatment time significantly for patients. What's really interesting to note is that we do not see bone loss in the zygomatic bone over time. In many of our grafted patients over the years, we tended to see bone loss around the implants, but we just don't see that in the zygomatic bone. What's also important to understand is that there's a real synergy between surgery and prosthetics. Although as zygomatic surgeons, we focus on the surgery, we really have to be planning these treatment solutions with our restorative dentists and our prosthodontists. These are prosthetically driven treatment solutions. Over the many years, there's been a shift in the reconstructive mindset. So when I was a resident many years ago, we were taught how to surgically rebuild maxillas, harvesting bone, grafting, all of the various nuances of the technique. And what we realized is that we actually can prosthetically reconstruct these maxillas. As you can see here, what's outlined in blue is zirconia. So the lost anatomy is rebuilt or reconstructed with the prostheses. The concept of using short implants anteriorly with zygomatic implants, or even in conjunction with the quad zygoma, is really controversial, and there are very few supporting studies. The authors suggest that if in the anterior maxilla there's inadequate bone for the placement of a 10 millimeter length implant or more, then a zygomatic implant should be placed, and the quad zygoma approach should be entertained. How do we plan with regard to the quad zygoma? The workup is really the same as any conventional full mouth rehabilitation. So we need to work with our prosthetic colleagues and understand what's required with regard to the prostheses, what's required with regard to the occlusion, the skeletal pattern. This is a joint effort that we as surgeons really need to be a part of and understand. We need to have a surgical guide to assist us with the placement of these implants, again, in the optimum prosthetic position. These guides have to have good palatal support because that's what's used to essentially support these guides once the surgical flaps are raised. From a radiographic standpoint, a panoramic radiograph serves as really kind of an initial scout film. But the key to this procedure is the CT scan and digital planning, actually performing the surgery on the computer, understanding the positioning of the implants, the anatomy, underlying ridges, potential pathology if it exists, so on and so forth. This is really key to the quad zygoma. Various surgical techniques have actually been discussed over the years and adapted from Professor Brannemark's original protocol. The classic Brannemark approach was one whereby the implant was completely placed into the sinus. In doing so, in many patients, we had to essentially perform an osteotomy and start that osteotomy much more palatal than actually on the crest of the ridge. As you can see here, by the positioning and placement of this implant, you can see the entrance of the implant is palatal on the ridge. Over time, this posed a problem for prosthodontists, patients, restorative dentists, just by virtue of the fact that the prostheses were bulky. Patients, unfortunately, in many situations, wouldn't tolerate or had difficulty tolerating these bulky prostheses. They seem to be more difficult for a restorative dentist to restore. And so this unfortunately gave the zygomatic implant a bad name. Over the years, a sinus slot approach was then talked about by Stella and Warner and published, really with the goal to position the head of that implant or the prosthetic platform much closer to the crest of the ridge. And this is a procedure whereby a groove or a slot is made essentially along the buttress of the zygoma to help position that implant in a more prosthetically driven position. In 2007, the exteriorized or extra sinus approach was discussed by Emilio Renca, and our very own Carlos Aparicio published in 2008, as well as in 2010. And this, I think, really substantiated for many of us the use of the quad zygoma, because inherently, in order to place an implant in the anterior maxilla, it's impossible anatomically to have that implant traverse an intrasinus path along the whole length of the implant if the prosthetic platform ends up in the lateral incisor or the canine incisor, which is the case when we use two implants to restore a maxilla when there's inadequate bone. So this really, Dr. Aparicio's and Emilio Renca's efforts and publications really, I think, substantiated what we were doing over the years when we found ourselves in situations where there was inadequate bone in the anterior maxilla. In 2010, Professor Chow published about the extended sinus lift procedure. And this was really to circumvent some of the sinus issues that we were seeing with the classic Brannemark approach. And finally, in 2011, Dr. Aparicio, I think very cleverly, talked about and published the ZAGA approach, Zygoma Anatomy Guided Approach, which really brilliantly illustrated and described the diagnostic exercise which we really should all be undertaking when we place a zygomatic implant. Whether that be a single zygomatic implant or a quad zygoma, we have to have a structured approach with regard to how we're going to place this implant, understanding the underlying anatomy, and really an individualized approach relative to the maxilla and the concavity of the lateral wall, as well as an understanding of the prosthetic platform and where we want it to be close to the crest, and also trying to minimize any sinus complications. So this really packaged for us the positioning of implants and underscored the importance of our diagnosis and planning. What do we need to consider when we place zygoma implants? It seems quite obvious, but it's important to include adequate mouth opening. If you think about it, when you place an implant in the posterior maxilla, a zygomatic implant, and you want to position that implant as far posteriorly as possible, we have significant length of our drills, our implants, and we need to have adequate mouth opening to place the implants and really perform the osteotomy. So please Make sure that you assess patient's mouth opening, and it should be at least 3 centimeters. Obviously, if a patient is edentulous in the mandible, that makes your job easy. If they have an implant retained prosthesis, full arch on the mandible, you can remove that, also to make your access easy. These procedures are typically done under IV sedation or general anesthesia. And of course, as with all implant procedures, a sterile field is a must. It's important when the patient is prepped and draped that you can actually palpate the body of the zygoma, the lateral orbital rim, and the infraorbital rim, because this really helps with planning the trajectory of your implant intraoperatively and ensuring a proper pathway with regard to the implant and really respecting the anatomic boundaries. In placing our incisions, very important to keep in mind that we want a good width, a good band of keratinized tissue surrounding the implant at the end of the surgery. So please make sure that this is more of a palatal crestal incision. At the end of the day, you just have to keep in mind, I want a lot of keratinized tissue surrounding those implants. Full thickness flaps are raised to essentially visualize the maxilla from the piriform apertures up to and including the zygomatic buttress, the infraorbital foramen, and just inferior to the infraorbital rim, and of course the zygoma or malar bone itself. When identifying the infraorbital foramen, it's really, really important that we protect this area, preserve the nerve, and illustrate to our scrub nurse with regard to retracting so as not to infringe upon that nerve and obviously cause trauma and damage to the nerve that can cause a problem for the patient. The best way to think about a quad zygoma is your goal is to place 2 implants within the body of the zygoma. You have a finite space, you have anatomy that you've got to deal with, and you need to place these 2 implants within the malar bone, and you also have to think about the prosthetic emergence, and you want to make that prosthetic emergence as crestal as possible. The anterior implants need to be placed first, and they emerge typically at the level of the canines or the lateral incisors, and the posterior implants are placed second, and they typically emerge in the premolar areas and sometimes, depending on the anatomy, in the first molar area. The implants have to be well spread for adequate AP support, and the goal for the implants is typically 35 Newton centimeters, and oftentimes we achieve much higher initial stability with zygoma implants. But keep in mind that if you don't achieve 35 Newton centimeters, it's really not mandatory because these are part of a cross-arch stabilization system. Very important to understand that these implants are never loaded in a freestanding scenario. You may see slight bending of the implant, and this is really due to the fact that there's really no integration at the level of the maxilla. Keep in mind, we're dealing with severely atrophic maxillas. And so without that integration at the maxilla, you really just have integration and stability in the malar bone. And if you were to try to move the implant, you would actually see it move a little bit. But it's not an issue because once the implants are connected, this movement ceases. Post-operatively, how do we care for our patients? Analgesics, anti-inflammatories, and antibiotics are prescribed. These patients have sinus instructions and routine follow-up up to 6 months after surgery. And typically, I see patients yearly for recalls to follow my patients. The final prosthesis is delivered anywhere from 4 to 6 months post-operatively. Like all surgeries, we have complications. So I think we need to, in fairness, discuss those complications. And historically, the most common complication really had to do with the sinus, either sinusitis or oral antral communication. But in fact, the prevalence of sinus pathology actually associated and caused by zygomatic implant surgery is actually really controversial. Although many people believe that the zygomatic implants were the cause of sinusitis, we really don't have evidence to support that. There is some, again, controversy with regard to the type of sinusitis. Is it allergic? Is it bacterial? Is it a rhinosinusitis? But suffice it to say that if you do have a patient who has bacterial rhinosinusitis, the management really is with antibiotics. If the patient's symptoms do not clear with antibiotics, there is then indication for functional endoscopic sinus surgery. And this is typically performed with our ENT colleague. So it's really important to have good relations with an ENT or ear, nose, and throat surgeon when you are performing or undertaking zygomatic surgeries. It's good that they understand what we're doing. It's also very important that these patients have a patent osteomeatal complex. The sinuses need to drain. That's crucial with regard to the endoscopic sinus surgery. Once these surgical endeavors are performed, patients typically will get better, and there's really no reason to remove a zygomatic implant. How do we prevent sinusitis? Good clinical history and preoperative radiographic evaluation. So we need to understand, we need to ask our patients, are they symptomatic? If we have any concerns with regard to the health of the sinus, the osteomeatal complex, we need to consult with our ear, nose, and throat colleagues, and the patients need to be treated as needed, as indicated. And where indicated, we need to use the extramaxillary or the exteriorized approach. Again, this is along with the ZAGA philosophy, which takes into account trying to minimize postoperative complications. Oral antral communication was also really a complication that was seen early on with the classic Brandemark protocol. And you can see here with the CT image and the implant place that if with the classic Brandemark protocol, we try to place this implant completely within the sinus, you can see that there's very little bone. And if we perform that osteotomy at the crest of the ridge palatally again, as you can see here, that if you over-prepare the site, it's very easy to have an oral antral communication. Or if there's any bone loss over time, as you can see in these radiographic images, it's easy to have an oral antral communication. There's also thought that perhaps a two-staged approach, placing the implant and having a denture on top of the ridge for months, potentially can cause bone loss by pressure of that denture on the ridge. And again, potentiating an oral antral communication. We really don't have any standardized evidence-based protocol or consensus with regard to the management of an oral antral communication. Different approaches have been reported, and most of them talk about the use of a buccal fat pad to close the communication. How do we prevent it? Again, I think caution in preparing the crestal osteotomy, immediately loading these cases, and really diagnosing these properly and designing preparation of the osteotomy according to the underlying anatomy. So again, thinking of that ZAGA protocol or principle with regard to positioning of the implant, minimizing our complications, and trying to get the head of that implant as crestally as possible. This is unfortunately a complication that we saw with the extra sinus or extra maxillary technique when there was discussion and early publications. You can understand if an implant is not covered by bone at the crest, that we can see tissue retraction. And the position of that implant relative to the crest can cause more retraction depending on how that implant is placed. Again, there's some evidence or suggestion, I should say, in the literature with regard to thickening the tissue, potentially using buccal fat pad to thicken the tissue, ensuring obviously we have good keratinized tissue. But what we also have to really think about is read the fine print. When we talk about the exteriorized or extramaxillary approach, it's easy to think that we just place the implant lateral to the maxilla. As you can see here outlined in the blue circle, this implant is truly lateral. It doesn't really feel like it's embedded in the maxillary walls if you compare it to the implant beside it, which is almost blends in with the maxillary anatomy. The one in the circle is protruding from the maxilla. This, ladies and gentlemen, unfortunately is a recipe for disaster and will certainly result in the tissue retraction, which you saw in the earlier slides. But this is how we all learn, and we get to educate each other, and you can learn from my mistakes. So this is what not to do. So we really need to get that implant embedded into the wall of the maxilla, and again, abundant keratinized tissue. Penetration into the orbit. I think with all of the technology that we have today, I think this is a complication that really should not be occurring. Certainly the quad zygoma approach, as I talked about earlier, the thought is placing 2 implants in a finite space. We have to first understand, can that finite space accommodate 2 implants? So we understand and know that the height of the zygomatic bone needs to be a minimum of 1.8 to 2 centimeters in order to accommodate 2 implants. So we need to diagnose and plan accordingly. We obviously have to be trained properly, be expert surgeons placing single zygoma implants, and have good knowledge, excellent knowledge of the regional anatomy, and plan properly. Use our digital technology to plan these cases, and potentially, if need be, consider printing a 3D model of the patient's maxilla and actually performing the surgery of the model if there's any uncertainties. So there's really no reason to go into these cases unprepared and with uncertainty with regard to the placement of 2 implants. So placing an implant in the orbit is a complication which really should not be occurring. Infection at the implant apex. This presents as an extraoral swelling just lateral to the malar bone. And as you can see here, there's a cutaneous fistula. You may not always see a cutaneous fistula, but in this particular patient, she presented with a cutaneous fistula. And this can occur years after zygoma surgery. The treatment is really surgical. The patient is prescribed antibiotics, but debridement of the malar bone is indicated, and removal of the apex of the implant. You have to remove the apex of the implant and debride the bone. Typically, an extraoral approach is performed. However, if you can access the body of the zygoma and the apex of the implant intraorally, certainly this can be done intraorally. How do we prevent this? The implant apex really should just engage the outer cortex of the zygoma, but please remember it should not extend beyond it. So it just wants to engage the outer cortex of the zygoma. Obviously, we have to have a sterile field and thorough irrigation prior to wound closure. Nerve injury, I've already pretty much alluded to this. Typically, this is temporary, but we really have to be careful to identify, preserve, and protect the neurovascular bundle, and careful retraction. Obviously, we're not doing the retraction as the surgeon, but to educate our surgical assistants to be cognizant of where the nerve is and careful when they're retracting. Implant fracture, this is really, really infrequent. I've only seen this twice since I've been performing zygoma surgeries. And this is typically really thought to be due to implant overloading. Again, reason why we have to have a good relationship and a good understanding of the biomechanics and have an understanding of what our prosthodontic colleagues are trying to achieve when we place our zygomatic implants. We need to remove the fractured coronal portion and replace the implant as needed. Obviously, the apical portion of this implant would really be difficult to remove because it's integrated, so that would be left in place. Again, prevent this by appropriate prosthetic planning, and obviously on our part as surgeons, appropriate implant positioning. Well, obviously they're not just surgical complications, but we all know that there are also prosthetic complications that occur: loosening of screws, fracturing of prosthetic teeth, frameworks fracturing, loosening of abutments. And we really manage this with our restorative colleagues. Typically, our restorative colleagues would be the ones treating this, and they really need to ensure and verify a passive fit of the prostheses and ensure the biomechanics are optimal. How do we prevent this? Again, the theme comes up time and time again: coordinated planning with our restorative clinician. So what do we know? What's really in the evidence with regard to the quad zygoma technique? Well, for starters, there's an abundance of evidence in the literature to date supporting the use and high survival rates of zygomatic implants when combined with anterior implants, anterior conventional implants. The quad zygoma concept really came into clinical practice years after the single unilateral zygomatic implant proved itself. So the literature in this regard is really reflective of this timing. And what that means is that we really have few studies on the quad zygoma procedure. The good news is this is not reflective of the international use of the technique and the frequency of its use either. What's also important to note is that these studies really show that this may actually be a better rehabilitation modality for the severely atrophic maxilla. The use of 4 zygomatic implants with an immediate loading protocol is typically predictable, and survival rates in the studies up until 2019 have showed survival rates from 96% to 98%. And this is with some data up to 5 years. Of course, more long-term data and more studies are needed. All of the studies did report complications, and that's obviously understandable. And again, what I will stress is this is really an advanced surgical technique. We really have to be excellent single zygoma implant surgeons before we undertake the quad zygoma approach. Our patients rightly need to be informed about the surgery itself as well as the potential complications. There are no randomized controlled clinical trials comparing surgical techniques for the placement of zygomatic implants. But it's the author's opinions that really the prudent approach is one in which the patient's anatomy dictates our surgical technique. And this is really the whole ZAGA philosophy. It takes each patient and enforces us to undergo a diagnostic exercise to determine the best position of this implant relative to the sinus, the crest of the ridge, and the body of the zygoma, looking at all 3 factors. And ultimately, the goal is to have a crestal position, minimize sinus complications with an apex well embedded in the body of the zygoma. What does the future hold with regard to the quad zygoma? Well, we obviously do need more studies, more quad zygoma literature, more outcome, immediate load literature, and I have no doubt that many of you will be contributing to the literature in the years to come within this ZAGA family. What's interesting is that there are some presentations in the literature with regard to digital surgical guides, the use of stereolithographic templates. What's really important to understand with those templates, however, is that we have to be sure that they accurately transfer virtual planning to the clinical setting. We really don't have much of a margin of error when we're placing 2 implants in small bodies of the zygoma. There's really no room for error in many of these cases. What's exciting is surgical navigation. I think potentially over time, we're going to hear more about surgical navigation with regard to zygoma surgery. I think the future is really bright with regard to this technological advance. With that, I want to thank you very much, and thank you again, Carlos, for this amazing opportunity for collaborative global education. Thank you.
Thank you, Dr. David, for the complete overview of the zygomatic implant treatment from start to finish, focusing on the quad aspect of it, or the quad variation of it. I think with the next speaker, we have quite a lot to say about quads also, Dr. Rubén Davó. And but yes, we could discover all about potential complications, obviously very solid pieces of advice to prevent these complications and not repeat the mistakes that you did in the past, as you clearly said. And this is very valuable. I remember the first ZAGA digital meeting where we shared mistakes we did in the past. this is of high value, and I guess the learning is what has to be taken from. And we have a first question from Dr. Michael Liss from the YouTube live stream, asking about the long-term stability of the buccal fat pad. What can you tell us about it? Is it stable? How long can you expect it to last?
That's a great question. I think we're actually going to be, correct me if I'm wrong, looking at a focus group, or that's one of these study club questions. So certainly that's been proposed as a manner in which to bulk up the tissue, to potentially close an oral antral communication, or supplement our soft tissue immediately at the time of surgery. Certainly we know that the buccal fat pad has been used since the late 80s in defects to close communications. And there's evidence to suggest, certainly because the fat pad is fairly well vascularized, it's a pedicle flap, that there is going to be some stability. But there's also some evidence to suggest, depending on what you read, that there may be a little bit of atrophy, but I think the answer to that is I don't think we know how much and how stable it is. I think there's suggestion that it's fairly stable, but if we get some atrophy over time, it's possible. We don't really have the answers at this point in time, but it appears to be, certainly when I've used it over the years, it's appeared to be quite stable, but anatomically, is it exactly what it was after the initial graft? It's hard to say. I think the benefit or the pro to it is that it is a vascularized graft.
Okay, we have a second question.
Or I should say pedicled graft.
Yes. We have a second question that is very, very precise. How did you find the malar bone in the replacement of zygomatic implant procedure? I'm not sure if...
Just repeat, how did I find the malar bone in the...
replacement of zygomatic implant procedure? Let me ask, perhaps Victor can rephrase the question. Please do this. Meanwhile, we'll take a question from the speakers. Dr. Aparicio, Dr. Chow, Dr. Davo, do you have a question for Lesley? Dr. Aparicio has a question.
Yeah, I have a question, yeah. Yeah, I'm thinking now on conventional implants, okay? So the work from Abrahamson or Linde came into my mind when we screw and unscrew an abutment. It looks that we are creating a scar tissue. And other authors like Link Vicious said that also the thickness of the soft tissue is important in order to preserve bone around the implant. Or also studies from Galindo, Spain, they say that also the height of the abutment is also important in order to preserve bone around conventional implants. So my question would be, do you think those parameters would apply also for zygomatic implants?
Yes, I think we're fortunate in that, given where we're placing these implants and given that the patient's edentulous, we have the opportunity to sort of place our incisions in a way that we can have significant thickness of tissue. And I do think that's really important, because unless we universally adopt Professor Chow's sort of approach whereby we're grafting at the crest, many times we just don't have bone there, whether we're placing them intrasinus or sort of lateral with the new flat implant. So I'm a firm believer, I think, even before all of this literature came out, that soft tissue is the thickness of the soft tissue around these implants is absolutely crucial with regard to long-term stability of the soft tissue. So I think we're fortunate in this way that we can create that, and we have to keep that in mind when we design our incision.
Thank you.
So
okay, we're still waiting for the questions. Professor Chow, do you have a question for Lesley David?
Dr. David, I saw you show cases with fracture zygomatic implant in court cases. So in cases we have a failure or a fracture, then what should we do? I mean, because nowadays we usually let the patient to have immediate loading. If this happens in a court zygoma cases, should we put the patient back to a removable denture, and how long should we wait for the healing before we can replace the fracture or the failed implant? What is your protocol?
That's a great question. So I've actually, in that particular patient that I showed, what we ended up doing, this patient, we still had their acrylic transitional prostheses. So we actually loaded the patient with a fixed prosthesis. So their transitional prosthesis was placed. And essentially what we did was decrease the distal cantilever, so it was shortened until such time that the patient could have the surgery. And then once the surgery was performed to place another implant, we then picked up that implant and immediately loaded that implant as well. So I don't think it necessarily means you have to commit the patient to using a removable denture. As long as the remaining 3 implants are, I think you can bypass that, place another implant, and as long as the stability, obviously, of the implant is good, then you can immediately load that implant and integrate it with the other implants.
A follow-up questions on this, because although we know that it is possible to see fracture of the zygomatic implant, but it is considered to be quite rare. So if we encounter a case with fracture, usually what is the cause of this fracture? And if I replace the implant, how can I prevent fracture in the future?
So yes, I'd like to add, Professor Chow, this is on top of very linked to the question that we received from the YouTube stream, which is how easy is it to replace a new implant after taking one out in case of fracture or any reason to take one zygomatic implant out?
So I'll first address, Professor Chow, your question. So the fracture, as you saw, was you didn't see the whole implant, you didn't see the pre-op, but it's typically in the middle of the implant. And if you look at the finite analysis testing, you see that most of the loading of the implants occurs sort of in the middle of the body of the implant and basically at the crest. So it fractured there, and I think the reason for the fracture was likely a biomechanical failure, an overload. So I think it was overloaded, so we have to go back and look at the prostheses construction. So that's number one. So the question then is, what do we do about it? So implant in that manner, you can either attempt to take that implant out. So how do we take that implant out? Of course, the fractured portion comes out quite easily. And then we have to make a decision. What do we do with the portion that's left in there? So the options are A, leave it as is. B, I would say cut it so that you don't have this protruding piece into the sinus and just leave the portion apical into the body of the zygoma. Or C, make the decision that for whatever reason, I need to retrieve this apical portion that potentially has no pathology because the implant just fractured, but there's no pathology. And I think, in my opinion, in order for me to retrieve that apical portion, I would have to have a reason. So either A, I want to put another implant in and I have no space, but then I'm going to have to be extremely mindful of how am I going to get that apical portion out because I want to preserve the remainder of the body of the zygoma in order to place another implant in. So that would be something that would have to go into my mind. And if there's adequate space, again, this really is going to depend on the size of the body of the zygoma, I might be able to navigate placing another implant in a different location, right? So that would kind of be my decision tree, if you will. Do I really have to take this apical portion out? If I don't, I'll choose another site. If I do, then how am I going to do that? So if you're now dealing with a fractured portion, you'd obviously have to make a window through the lateral wall of the sinus, like a Caldwell-Luke approach, and gently and carefully keeping in mind that if the body of the zygoma is very small or thin, that you could fracture it if you over torque it. How am I going to actually grab onto that portion that's fractured. It's now a rounded implant. Do I drill it and make it more square-like so I could actually get it off? Or do I then think about, I want to preserve the bone, maybe I need to drill at the entry into the body of the zygoma, drill the actual titanium as opposed to drilling bone and creating bone loss around the implant. So these are all factors that I would have to consider. I can't say there's a recipe, but these are all sort of the things that would go through my mind in terms of removing this and navigating, putting another one in.
Dr. Davo, do you have a question for Dr. David?
Yes, thank you, Lesley, for your presentation. I fully agree with all the things you have said. Just to add, I have only seen one fracture of zygomatic implant, and the cause was very obvious, the loosening of the cross-arch stabilization. Quad zygoma especially is a cross-arch stabilization system. As soon as you have some mobility because one of the screws is loosening, you can have a fracture because you are going to have overload. This is the only case I saw. So that's why it's so important that I advise my patients, as soon as you notice any mobility, please phone us as soon as possible, because if you have this problem, you can overload one of the implants. And the loosening of the cross-arch stabilization system is really, really important in all the implants, but in quad zygoma especially. And I would like to ask you a question, Lesley, because we have a limitation when it comes to the preservation of the bone in the quad cases. We have a limitation because it is absolutely difficult or even impossible to evaluate the amount of bone we have there. If we are dealing with people who are having 2-3 millimeters of bone, because if you have more, you are not going to place a zygomatic implant, so you have very little bone. And with the pass of the time, it's really, really difficult to evaluate from the radiological point of view the bone we have. The only thing I do is to check with a proof in order to see if we have some filling with bone, okay? But with the X-ray, because of the positioning of the implant, it is absolutely difficult. Of course, the CT scan is impossible as well. It gives us no information. So what do you do? What I do, I have told you, is just to check with a proof if we have savings of bone. Many, many, many times I don't find any bone at all. So I totally agree with you. The most important is the preservation of the soft tissues and to have a very thick soft tissues. Do you agree with me, or what is your opinion on that?
I agree with you. Yeah, as I said, I agree with you 100%. I think, yes, I think by virtue of what we've done over the years with regard to the evolution of placing these implants sort of extra sinus, that is the savior. I mean, we just aren't going to have a lot of bone in these cases, and the only way is to actually visualize it or probe the area. And at the end of the day, I think our soft tissue is the key. I really do. I mean, we've seen patients, if we kind of extrapolate and look at sometimes implants that were placed in resorbed cases, sort of, and you see, crestal threads on the palatal aspect in a conventional sort of tilted all on four, so to speak. Initially people were grafting those, and then we found, as long as we have thick tissue, I think we're pretty good. So I feel I have the same philosophy as you.
Can I comment something, David?
Sure. Yes.
Thank you. Yeah, I fully agree that when dealing with zygomatic implants, the traditional method to illustrate how much bone per implant bone we have or we have loose, so we cannot make traditional X-rays because we cannot see that because of the physical difficulty of placing the film on the palate. The palate is flat, so there is no room for the film. But I will, because it's good to have some controversies, to have some different point of views. I'm not for using traditional methods to measure dental health, like dental proof. I don't like to transport those methods to the zygomatic implant. What I mean is that whenever I want to assess how much bone I have using a dental proof, I have to sound bone. So I have to, in a manner, let's see, jeopardize the soft tissue junction, the hemidenmosomal junction around my zygomatic implants. So this is like a contradiction. From one side, we are saying that soft tissue sealing is so much important, and on the other side, we are using the dental proof, which meaning that we are separating those circular fibers from the titanium, and then we are like exposing connective tissue. Connective tissue, as we know, doesn't like to be exposed to the oral cavity. So whenever the soft tissue, the connective tissue is exposed to the oral cavity, what is going to do? He will shrink some bone in order to. So, of course, if you do one time, is not important probably, but too much using the dental proof to me is, especially in those difficult cases of having 1 millimeter of bone around my implant neck. So I do prefer not to use it, because at the end, what I'm going to earn by using this. So if by placing my dental proof, maybe I will get some blood, maybe not, but this is clinically important.
Yes, it is important, Carlos.
No,
Sorry.
I don't agree with you, because
No. Can I explain? I totally agree with you. I only prove when it is necessary, when I have some doubt, if necessary. So very often I don't think, do I have bone at this level or not, because it doesn't really matter. If it works, and there is no problem. Just in case, I prove in order to check if there is bone or not, because if the patient has a complication or whatever, the attitude is different. But I fully agree with you. We have to avoid the proving in this area, and if we do that, we have to do it very carefully and as less as possible. I fully agree with you. But we don't have another X-ray. This is the problem, because in all in the conventional implants, if we have any doubt, we make an X-ray and we can see the level of bone, of if they have periimplantitis or whatever, but not in the coronal part of the zygomatic bone. Zygomatic implant. So this is a limitation we have. I will discuss on that in my presentation.
So I'll interject as well. So Carlos, you bring a very good point. And I will say I do agree with that, in the sense that when I see patients and give the final go-ahead for proceeding for the final prostheses, so I will remove the prostheses, check the implant. If there's any erythema or something I'm concerned about, that I don't know if that's what Ruben's saying, but I will definitely probe if there's something. So I usually use my finger. I use my finger to palpate. I use my finger to see if I can get some mobility. And then if I have any concerns, I will probe. But again, I will probe gently. But after that, when I see patients every year for follow-ups, I absolutely do not probe. And to the extent, your point is very well taken, and I think needs to be said, that I will actually tell the people with whom I'm working, when you remove that, please do not, because oftentimes the restorative dentist, depending on who you're working with, there is this thinking that they need to take a scaler around the implants, and there's special scalers for titanium, and they need to go around those implants. And you're right, you do that and you probe and you're not cognizant of what's underneath, and there you go, you have a presto oral antral communication and a problem. So I actually do take it a step further to tell my restorative dentist, if there's an issue, please just send the patient back to me. When you do the hygiene recall to see this patient, do not actually use titanium scalers, whatever scalers you want to go around those implants, just leave them. just send the patient back to me. So I agree. It's a point well taken.
Yeah. I think you, for sure, you also, Ruben, you know that the implant head usually has a corrected angulation. That's another point. So it's not the same proving on one side or on the other, because if you prove, let's say, on the vocal side, usually your proof will end up on titanium. Whereas when you prove on the lateral side, you will end up on bone. Or if you prove on the, let's see, on the lingual side, you will have a deeper proving. So I call it emotional proving. Emotional proving. This is like a dentist defect that I know that, Ruben, I know that you know what you are proving. But allow me address this generally speaking. Please don't prove. Don't prove, because you are not going to get any useful information. And this is, again, it's not for you, Ruben, because you are an expert. I would say to the dentist, please don't prove my implant. I will say to any restorative dentist, please, as Lesley said, forget about that.
The conclusion is very sad, because we don't have to prove, but many times the proving is the only way to diagnose oral communication. This is the thing. Because by means of an X-ray or CT scan, many times we cannot be sure, because we have a distance to the implant and the direction, etc., and it is very difficult. But once I have said that, I fully agree with you. To prove just if necessary, and of course not proving everything, because I totally agree with you. The connection of the fibers, everything are very important. So
If you allow me, I will come back to James. When James said that we don't know why I have a oral-anterior communication, and we don't know why this side has a sinusitis and the other not.
That's from Ruben's probing.
But allow me to say something, because proving is not going to change anything. The only thing it can do is put the things worse, contaminate, and create. You may have an oral-anterior communication, and this communication is not correlated with sinusitis. Okay, so, but by proving the doors for bacteria to come in. Do you know my point? That's my point. So at the end, my surgical attitude is not going to be independent of this proving, because I think, again, and maybe we are going to laugh, it's an emotional proving that comes from teeth to conventional implants and then to zygomatic implants.
So can I ask a question, Carlos?
Yes, sure. That's
Dr. David, you will have the last question to Dr. Aparicio, and then we'll move on to the next speaker.
Okay.
Carlos, we will speak later on in private if you want, but if we cannot make X-rays, because we all agree that X-rays are not exact and accurate to diagnose that, and we cannot prove, what are we supposed to do? In the cases we are thinking that the patient could have this. So this is the thing.
Yeah, the answer is very clear. Does the patient has clinical symptoms or not?
Yes.
Then treat it.
Okay. So Carlos, I'm gonna have to agree with Ruben here. I agree with what you're saying with, for sure, in general. I think we all agree the same thing. But if the patient has symptoms, right? So, and you take an X-ray, you take a CT scan. So are the symptoms the patient just has a sinusitis, or does the patient have an oral-anterior communication that may or may not be related to the sinusitis? You don't know, but do they have an oral-anterior communication? So the only way you can determine that, because you cannot get a read on the CT scan, is to probe. How else are you going to determine that?
It's very easy. Allow me to. Okay, I finished, David. Okay,
yeah,
David.
You have 30 seconds.
I will finish. Okay. So we are supposing this patient has a rhinosinusitis, okay? Because he has or she has clinical symptoms. That's the point. We make a CBCT, and okay, it's opaque, so it's coincident. We have clinical symptoms and radiological symptoms. Tell me what my treatment is going to change, or how my treatment is going to change by proving or not proving.
Well,
it's not going to change anything. I will treat this patient medically first, and then if not, I will go for an ENT or whatever.
But if you don't know,
proving is not going to change my treatment, my attitude.
But so if you think a patient has an oral-lateral communication,
yes,
right, or you don't diagnose it, so I guess the big question is then to ask is, do you think that an oral-lateral communication needs to be treated? Do you think it's potentially exacerbating or causing the sinusitis? So if you don't know that the patient has one, how are you going to treat it? Or do you just say, we're not treating an oral-lateral communication, I'm just going to address the sinusitis? Pardon me?
Because I don't know how to treat it.
Okay.
That's my point. I don't know how to treat an oral-lateral communication.
Okay. David, can I say something in 10 seconds?
10 seconds, it's accepted, yes.
Yeah, 10 seconds, no. One thing, for me, it's important, one thing for the treatment of patients who have any problem. But the second thing is from the scientific point of view. After 20 years, we don't have a clear evaluation of the stimulation at this level. This is something incredible. But, we cannot say what happened with the bone at this level. And that's why I fully agree with Lesley. After 20 years, I think that the soft tissues, to have a good thickness of soft tissues, are fundamental. Because if we have our oral communication or not, probably it is not that important. This is my conclusion. But I cannot prove that. I cannot prove that because we need clinical studies. And if we don't have serious clinical studies on that and very futile, very very specific clinical studies, in 20 years, we will go on speaking about that. This is my feeling. Because sinus...
I think this is a topic we are adding to the study club without any doubt.
Yes.
And,
because it's a very controversial, but we need more, specific and directed clinical studies. This is my feeling.
Yeah.
Thank you.
Thank you for the discussion.
Ruben, I have another problem with you, which is, again, just like Professor Chow and Dr. David, length of your curriculum. I tried to summarize the best I could. So we're moving to the next speaker, Dr. Rubén Davo. Again, not much of an introduction needed, but Ruben is a doctor of medicine and surgery at the University of Alicante, summa cum laude, by the way. His doctoral thesis was about immediate function in the atrophic maxilla by means of zygomatic implants. So we're right on spot with today's topic. And well, Ruben is an international speaker, researcher, well-known publisher. I think we all know the study about the comparison between the quad zygoma and the bone grafting techniques. So please, Ruben, go forward. We'll be listening to you for 15 minutes, giving us your impressions, your findings, and your observations about this study. And we'll be live again during the Q&A right after.
Okay, thank you very much. It's a pleasure for me to be here with you. And we are going to discuss during the next 15-20 minutes on a clinical trial we developed between 2012 and 2015 approximately. And it was in order to compare the zygomatic implants and the augmentation techniques in the extremely resorbed maxilla. So the first thing we have to think is why we decided to go for this clinical study. The treatment of the resorbed maxilla, the treatment of the extremely resorbed bone, the maxillary bone, is a matter of controversy during the last 20 years, I would say. The classical approach normally involves the use of autologous bone. It seemed to be the gold standard, but we have to consider other aspects like the morbidity at the other side, that the bone is resolved when it is subjected to loading. We have to consider the prolonged treatment timeline. And many people is recognizing today that it is often impossible to achieve an adequate internal and peripheral vascularization of the graft in large vertical reconstructions. That's why it is really difficult to state which is the best technique when it comes to the regeneration of this sort of bones. When it comes to the use of biomaterials, we have exactly the same problem. We have thousands of studies showing that regeneration is successful when it comes to small pieces of regeneration, small defects. But when it comes to the totally atrophied bones, we have very low number of studies, and it is really difficult to draw any conclusion. On the other hand, zygomatic implants during the last 20 years have experienced like a revolution, and we have more and more evidence that support that probably it is the best treatment for this modality of patients. We have today a long-term studies when it comes to the quad Zygoma approach, showing very high success rates. We have published very recently with Lesley David the quad Zygoma approach in the clinics of North America, showing as well very high success rates. And we collaborate with the Ninth People Hospital from Shanghai in order to develop a systematic review showing 98% success survival rate for the quad Zygoma approach. So in this circumstance, when you have two techniques appropriated to treat one specific pathology, the most important is to try to develop a randomized clinical trial in order to compare both techniques in the same population. The participants of the study are divided by chance, randomizedly, into separate groups that are going to compare the different treatments. For these reasons, the groups of people are going to be very similar, and the effects of the treatments they receive can be compared more fairly. If you look at this scheme, you will see that the randomized control trials are very high in the level of evidence. Above them are the systematic reviews of randomized clinical trials, but this is not applicable because as far as I know, this is the first and the only one randomized clinical trial when it comes to the Zygoma and regenerative therapies. The results of this study were published, the 1-year follow-up in the European Journal of Oral Implantology, and the 3 years follow-up very recently in the clinical trials in dentistry. And what about the indications and the material and methods we used for the development of this study? The first thing we have to say is that it was a 3-center randomized clinical trial. Thank you to my colleagues from the Hospital Clinic in Barcelona, especially to Carles Martí Pallés and Ada Ferrer, and to Roberto Pisilli from Rome and Pietro Felice from the University of Bologna. It was a balanced randomization. We used balanced randomization and blind outcome assessment. All the patients were classified as K-Boot number 5 or K-Boot number 6. And we divided and we assigned in a randomized way the patients to 2 different groups. The first one was the augmentation group and the second one, the zygomatic group. And what about the surgical procedures? When it comes to the regeneration, we chose the Sinus Lift using biomaterials. We performed the Sinus Lift using a big amount of biomaterial. We waited for 8 months, and after we placed the implants, and after 4 months, we load the prosthesis. When it comes to the Sagoma implants, we followed the protocol we published in 2010, showing the results we were having using quad approach by means of immediate loading protocols. The positioning of the implants were inside or outside the sinus, depending on the anatomic circumstances of the patient, especially the curvature of the lateral wall of the maxilla. That's why, depending on the different anatomies, we place the implants in a way or in other way. But you have to consider that the anterior implant, in the vast majority of the circumstances, are out of the sinus because of the anatomical circumstances of the patients. In 2011, Carlos Aparicio proposed the Saga classification, and we saw that it was very similar to the one we were using and proposing, and that's why if you go to the publications, you could see that we were following approximately this philosophy. I am not going to analyze all the results we had because it's going to be very boring, but I would like to show you some numbers. The first one is that, as you can see here, 82% of the patients of the Zygoma patients were treated by means of quad approach. All of them had no bone at all in the maxilla. That's why we went for the quad approach. The second thing is the total number of implants. We placed 141 zygomatic implants and 238 conventional implants. These implants were from Nobel Biocare, the classical thionite Nobel Biocare implants, and the conventional implants were Nobel Active implants. And two or three more interesting things are that Zygoma implants with the neck, in 80% of the patients, we managed to embed the neck of the implant, of the zygomatic implant, in the crestal bone. It is interesting. And we found that 62% of the implants have exposed threads, which means that at least part of the traject was out of the sinus. And which were the results we found? Again, I am not going to repeat all the results we evaluated. For those of you who are interested in this, in to go deeper, of course, they are in PubMed, but you can feel free to contact me or David Pastorino in order to have the papers. I'm going to point out the most significant results. When it comes to the prosthetic failures, we found that 6 prostheses in the augmentation group failed, and 1 prosthesis in the zygomatic group failed, which is different, of course. And when it comes to the implant failures, we found 42 implants failing in the augmentation group, around 18%, versus 6 implants in 3 patients from the zygomatic group, which means 4%. It means, that we have a statistically significant difference when it comes to the failing of implants. But the most impressive difference was the time to function. Since we use immediate loading protocols in the zygomatic group, we treat the patient in 1.2 days, the average. But in the regenerative group, the time to loading, the time to function was around 440 days, which means a strong and dramatic difference. And when it comes to the complications, which were the complications we found? In the augmentation group, the sinus membrane perforation was very frequent. It was solved by means of membranes, but the surgical procedures took longer, much longer, because to repair a perforation of these sinus membranes sometimes is quite difficult. We found no homogeneity in bone maturation. That's why we found a high level of failing implants, and we had to replace implants in this group quite frequently. And in 3 cases, we had to treat the patients in in a rescue surgery by means of quad zygoma, because they had failing of all the implants, and we had to use zygomatic implants to treat them. And when it comes to the zygoma group patients, the paresthesia of both infraorbital nerves was the most frequent complication. It was transient. It took 1 week, from 1 week to 3 months, to recuperate absolutely the feeling, the sensation on this area. And of course, we had some sinus problems and some jugal mucosal retraction and infections. It's important to state that the sinus pathology was an exclusion criteria. Theoretically, the patients who have any problem at the level of the sinus were excluded from this study. And what I have seen while processing the information, etc., from the different centers, is an absence of a clear definition of sinus problem, of sinusitis. It is very common in the dental and maxillofacial community not to have a clear diagnosis criteria to establish we have a sinusitis, a sinus problem, or whatever. But what we found was that in 4 patients, the theoretical sinus problem was treated by means of antibiotics, and that's solved, and it was solved. And in 3 patients, we treat the patients by means of functional endoscopic nasal surgery, that it has been described not only by me, but Carlos Aparicio and Bedrosian, etc., as probably the best approach to solve this problem. When it comes to the jugal mucosa retraction and jugal mucosa infection, etc., we have a low number of patients who experience these problems, a very low number of implants. The vast majority of the implants were like this, showing stability of the soft tissues. But again, we found in a small number of patients this problem. And it is important to say that it was unpredictable which patients are going to have these problems and which patients are not going to have these problems. So to finalize, and after we will go on with the discussion, the most important conclusion is that, from the prosthetic failures perspective, from the implant failures perspective, etc., it is quite, the results were quite different and favorable for the zygomatic implants. And of course, from the time needed to functional loaded, the results were dramatically different in favor of the zygomatic implants. So the conclusion is that after 3 years, because the last publication is the 3 years follow-up, all the patients were followed up for at least 3 years. Even if more complications were reported for zygomatic implants, they proved to be a better rehabilitation modality for the severely atrophic maxilla. Long-term data are absolutely needed to confirm or dispute these preliminary results. But there are more conclusions. The first one is that maxillomandibular discrepancy was not an exclusion criteria, and we didn't correct any maxillomandibular discrepancy in both groups. So one important conclusion is that cantilever can be solved prosthetically. This is important because sometimes there is still controversy on this topic. In the Italian groups, in 30% of the patients, they use grafts or Bichat adipose tissue to cover the threads of the exposed implants. But we haven't had any specific conclusion on that. This is something I don't like. Normally I don't use these techniques, but the conclusions on that are totally unclear. One important thing was that the marginal bone loss was not possible to study on zygomatic implants. This is a limitation we have when it comes to the study of the integration on the coronal part of the zygomatic implant because there are not specific radiological images to evaluate the bone there. 70% of the patients have the coronal part of the implant embedded by bone, but it was not possible to evaluate specifically the prognosis of this bone. One important thing is that we have to define exactly the sinusitis criteria, because I have seen a sort of confusion on that. But the majority of the sinus problems seems to be solved with medical treatment, with antibiotic, etc. And just to finalize, I would like to show this image. For me, is perhaps the best way to place the zygomatic implant, but it is my opinion. We have to prove that, in this situation, in the lateral wall of the maxilla, theoretically, you are not going to bother the sinus cavity, and you're not going to have pressure on the soft tissues covering the implant. But I repeat, this is something we have to prove. We can place the implants like this and have these fantastic results. Of course, these are the new Straumann zygomatic implants, and that for me, they are very promising in order to solve the slight problems we are having with the classical designs of zygomatic implants. And that's all. Now we have a discussion, and I will be more than happy to answer and to discuss, to answer the questions and to discuss with you. Thank you very much.
Thank you, Dr. Davo, Ruben, for this complete presentation. As we all know, this study is somehow a cornerstone of the research in zygoma, quad zygoma, especially comparing it to the bone grafting. And what a finish. That clinical picture of the flat implant is impressive. The right balance between getting into the sinus and reducing the soft tissue tension. I have quite a few notes, and we have already 2 questions from the chat. My first note was on top of your curriculum, which is that you've recently joined the ZAGA Council. So I would like to give an official welcome to you. And the second note is that the study club on the quad zygoma will be especially interesting to you, and especially to have you on board. I know Lesley David is also subscribed and registered to this study club, as well as 4 or 5 more surgeons already. And this is, as you said in the last part, important to separate what is your recommendation, your experience, and what you can prove. So we'll make sure that the intuition you get from these last results transform into solid scientific results that we will publish, obviously. So jumping into the questions, the first question is by Dr. Boris. What do you mean by jugal? If it's mucosa or if it's gingival?
Yes, the vestibular mucosa.
The vestibular mucosa.
Yeah.
Okay, I think, Boris, let us know if it does not answer your question, but I think it does.
No, the thing is that it is, yes, it is important because this mucosa normally in the quad zygoma patients and the single resolve patients is very special. Normally we don't have a lot of keratinized tissues, and it is more jugal. Jugal means free mucosa. With it.
Okay. The second question we have from Dr. Michael Liss, asking about the topic that Dr. David covered a bit. What about penetration in the orbit? How to prevent and how to manage?
Well, my colleague, friend, and teacher many years ago, Chantal Malaves, used to say that the penetration of the orbital cavity is not a complication; it's a mistake. So I think that we have a lot of tools today to avoid that. Even with these tools, when the zygoma bone is less than 1.8 millimeters, sometimes it's quite difficult. But the most, well, here I can say what I do normally. This is very, if the patient is under general anesthetic, you can place your finger in the floor of the orbit and to control exactly where the implant is appearing. Okay. And if you have the infraorbital nerve and the zygomatic nerve here in this area. You can see while operating, and you are all the time above this, not under this. Probably you are going to avoid the orbital rim. Okay, the orbital, to be honest, you normally in the quad zygoma you are quite comfortable because normally you have more than 2 centimeters of bone. This is the reality. But please have a planification. If you have 1.8 millimeters or something, or even less than that, because there are cases in which you can have less than 1.6 this measure. Please be very careful. Very careful because you can have this problem. The second thing, just in 10 seconds, no publications have came up with big problems related with the penetration through the orbit cavity. This is something important to say because you have the eye, but under the eye you have the fat in the orbital cavity, and to hurt the eye is quite must be quite infrequent, and very once you have noticed you have penetrated, you have to remove everything and to go for another direction, of course.
Ruben, can I add something?
Yes.
So I think I totally agree with everything you've said. The one thing I think that has helped me over the years is when you plan these cases to do a quad and you're planning that anterior implant, really make sure you look at the cross section of the apex of the implant such that you can see the orbit and the distance between sort of the orbital cavity and the lateral aspect of the orbital rim. Because in some patients you have pretty thick bone there, and in other patients it's really thin. And if you only sort of plan the implants and look at a frontal view or a lateral view, you can be fooled and think you're not going to be sort of into the lateral orbital wall. And again, we're not talking about penetrating. I don't even like to breach the cortex of the orbit. So if you really make sure that you scroll slowly through the apical cross sections to really get a sense in your mind clinically, okay, I have a lot of thickness here or I have little thickness here. That also makes you feel good.
Yes, and it is important. I totally agree with you. And you have to consider, and you know that as a maxillofacial surgeon as well, that the orbit has a curvature.
Exactly.
Okay, and that's why my recommendation is always to maintain at least 1 centimeter from the orbital rim, because I repeat, the orbit has a curvature. So even if you are sure that you are emerging on the zygomatic side, you can be jeopardizing the orbital flow. Okay, I can tell you that in 20 years I haven't had any single problem on that. Okay, but of course I have had penetration at the beginning of my career, when I started. But the most important thing is to remove as soon as possible the drill and to go for another direction. And the second thing, please pay attention when the zygoma is less than 1.8, 1.7, because it can be very difficult. I would say that for beginners in quad zygoma,
Dr. Ruben, I'm sorry to interrupt. It seems that we have no sound. So let's give us a minute. See on the chat that there is no sound. Radu, can you take a look?
Hello?
Okay, we hear you. I think we all hear each other.
Yeah, I can hear.
I can hear.
Okay.
I can hear.
Me too.
Let us ask the participants if they can hear you.
No, the only important thing, I don't know if they have, a quad zygoma, when the bone is less than 1.7, 1.8 millimeters, can be extremely difficult. So I recommend for the beginners in quad not to perform these cases, or to refer to more experienced
I'm looking at the chat now. Can anyone hear me now?
Yes, I can hear you.
Yes,
Radu is making some trials.
So Radu, we can switch back to the full view with all the speakers. And Ruben, if you can please, I'm sorry for this, repeat the answer to the question we just discussed, maybe in a summarized way to...
Yeah.
Thank you.
Yes, Lesley, I fully agree with you, and there are so many things that we have to consider. The first thing is that the orbital flow has a cure. So even if you are sure that you are on the zygomatic bone, maybe that the part of the implant could be in the floor of the. Sorry. You have to be sure that you have to take into account, and that's why it's so important, the planification, that the orbital floor has a curvature and you can be penetrating the orbital floor, and after going out on the zygoma bone. And the second thing is that when you have less than 1.7 millimeters, approximately 1.6 approximately, you can be in problems. That's why I don't think it's for a beginner quad practitioner. I think that it is a high difficult surgery. Probably it would be much better to make with another person, another surgeon who have more experience. So yes, the orbital cavities, we have to be very careful with it. And it is important to start with anterior implants, okay? And once you are sure, because to place the posterior one could be much more comfortable. You can even place the implant at the beginning of the arch, and you are going to be much more comfortable.
Ruben?
Yes, please.
I think, well, first of all, I'd like to congratulate you, not more than congratulate you, to thank you for this absolutely milestone paper you published. I think the surgeons that are practicing this, are using this way to rehabilitate the patients. We needed this paper. We needed to be sure that this kind of treatment is more predictable than the grafting procedure. So I think this is really a milestone paper, and this is 3 years now, and then I think you are going to publish in further editions probably. And I like to state that in front of the audience, because at this moment, this is the unique paper, as far as I know, that there is a randomized control study showing the differences between the grafting and the treatment with zygomatic implants. Okay, say that, I think I would like to ask you something. You are probably one of the most experts in the world on this quad procedure. So this means that you are one of the most expert treating with the most atrophic maxillas, because the indication for the quad is, as we all know, no bone in the anterior, no bone in the posterior. So say that I'm curious to know if you are experiencing an increasing number of patients needing this kind of treatment, and if so, the question would be also, can you relate this increasing number of patients needing a quad procedure with failing implant treatments, with failing implant and grafting treatments?
Well, first of all, thank you very much for your words. I have to thank to Marco Esposito. I have forgotten him, but Marco Esposito was the promoter of this study, and of course, thank Marco if you are hearing. Yes, I agree with you. More and more people are asking for quad zygoma. More and more referral dentists are sending for quad zygoma. There are many reasons to that. I think that there are many, but the first thing is that people start to think that quad zygoma has a solid base, a basic, a scientific background, and people trust, the surgical world, the dental field. They trust more on this modality of treatment. The second thing is that more and more people are knowing about this technique. Carlos, you have been with me, well, and Lesley and James from the beginning, nearly the beginning, and it took a lot of time to convince people that this work, etc., etc. So people, when I say people, I mean dentists and maxillofacial surgeons, they feel more comfortable in treating these patients in this way and in sending patients as well. And the third thing is that more and more people are recognizing that graft approach are not ideal for the total edentulous patient. And it has it has taken a lot of time that many people recognize that probably it is not the best option for this modality of treatment. And yes, of course, I would say that 60-70% of my patients for quad approach, I don't know, but at least 50% are after failing implants, long-term perimplantitis. And it is very interesting because it's a very particular patient, because they don't trust on implants anymore. They say, no, I don't want to listen about it. But if you speak about a graft, you speak about waiting 8 months, and after blah blah blah, blah they say no, please. But if you offer a immediate loading technique, it is much more easier for them to accept. So this is my opinion. I fully agree with you. I think, to be honest, that quad zygoma, I don't know. I know the situation in Spain, in Europe, and in the States. More and more people are not discussing anymore about the predictability of this modality of treatment. Of course, we have to solve some problems, sinus problems, mucosa. That's why I'm here, but the base of the treatment is not discussed anymore. This is my opinion. I don't know if you agree with me.
I do.
I think, Ruben, there's something to link to the ZAGA Centers podcast that we're editing and recording. We already have 10 episodes, and one of the most appreciated aspects of zygomatic implants is immediacy. And in the study, you showed 442 days of difference between the bone grafting and Zygoma implants, obviously. And this is, for the patient, this is a major difference. And so we'll take 2 more questions. One from Dr. I lost him in the feed. Doctor from the audience, and another one from Dr. David. So please, Lesley, if you want to go forward with your question.
Thank you. So Ruben, obviously, again, I echo Carlos, amazing paper. Look forward to seeing the long-term more data, but you've contributed to the literature on quad zygoma more than anyone. When I reviewed it, I thought, it's all Ruben. So all of our data is Ruben, and you continue to forge ahead. So thank you. I have 2 questions. One of them is, this is a 3-year follow-up study. And you talked about the bone augmentation procedure, correct me if I'm wrong, is solely doing a sinus lift. So you did no bone augmentation in the anterior maxilla, but you made a point of saying that these patients are, severely resorbed and have very little bone. So, do you think the quantity of the bone in the anterior maxilla, which wasn't grafted, is a contributing factor to the failure? So it's multifactorial, that's 1. 2, you talked about a lot of failures of implants. My question is, were they implants in the anterior maxilla where you didn't graft? Were they failures in the posterior grafted sites? How early were the failures? Because oftentimes when we do these grafted cases, I've seen some of my own, the failures can be immediate, but they're many, many years beyond 3 years later. So I'm just curious about that part of it.
Yes, it's a very good question. You know, in the vast majority of the patients, we didn't perform any horizontal augmentation. We decided to perform a big sinus lift because the patients were, vast majority of the patients were cable 5, cable 6. Okay. In some cases, we had some bone in anterior, but just 4 or 5 millimeters of bone. If they were I redo the answer because I was thinking of Zygoma. I don't know exactly. In the zygomatic group, 80% of the patients for quad zygoma and 20% for the combination of two conventional implants and quad zygoma. As it was randomized, we have to think that the other group was more or less the same, but we don't know exactly. I have to check, and I don't know. I know my cases in Barcelona, but I don't know in Italy and Rome. But probably, because it was a randomized clinical trial, both populations were homogeneous, were more or less the same. This is something we have to assume. So the vast majority of the cases, it was a big reconstruction of the sinus, a trial of big reconstruction of the sinus. In some patients, we placed some blocks as well, but very little, very little group. Most of them were big sinus lifts. This was the reality. What we found is after 8 months of waiting, sometimes in the same patient, in some areas, the bone was very soft, but 1 centimeter close, the bone was all right. You understand? It's very an homogeneous maturation of the bone. Okay? In both groups, well, if I have 1 minute, what happens, what is important is the difference between the 1 year and the 3 years follow-up. Okay, so of course we have more failings in the regeneration group. We have around 20% of failures, which is not quite high. We are speaking about cable number 6. And when it comes to the Zygoma group, in the first year we had just 2 implants failing, and in the 3 years we had 6 implants failures. Okay, but in one patient, it was in Italy, they had to remove the implants. And if you read the article and you read the problem, and when I I talked to them, etc., I didn't understand exactly why I removed the implant.
Ruben, okay? Ruben, one second. We lost sound again. We don't know where it comes from. We lost sound again. So please pause 1 minute, and we'll finish the answer as soon as the sound comes back.
Okay.
Lesley, was this your first question or your 2 questions?
That was the first question, then I had a very short second one. More for the audience. I think they would appreciate the answer.
Okay.
I answer? Do I have to respond now?
Wait a second still. I'm waiting for confirmation.
So you are going to make another question, let's see, now.
I don't have to. I don't have to.
You can. Okay, I believe we're back.
I have a question for Ruben.
Yes.
So it is a side track question because your study, same as Carlos and Lesley, I appreciate very much your work on this topic. But I have a sidetrack question regarding partial cases. Say when we are dealing with partial cases with very limited bone in the posterior maxilla, will you? I mean, under what criteria you will choose to do zygomatic implant instead of sinus lift grafting, or you actually, recommend grafting instead of doing zygomatic implant, which is different from in edentulous cases. What is your opinion?
Well, I have a presentation in the next global symposium of Straumann about that, and it took around 20 minutes. Yes, well, to summarize just in 2 minutes, the academia and the literature and everybody agrees, and that, grafting procedures are the first indication for partial cases. The main reason is that quality of life is not as affected as in total edentulism, and we are not in a hurry. We have time. Okay, but I think that there are some, for instance, when grafts have failed, of course, zygomatic implants have an indication. For when implants have failed in one lateral case, zygomatic implants have a clear indication. There are more circumstances, and for me, the most important thing maybe could be the psychological and social indication. Many people, I offer them to make, to perform graft for Zygoma, and they want Zygoma because of immediate loading, because of predictability, because of many things. So I think that in the next future, probably these limitations are going to change, and more people are going to use the unilateral Zygoma cases because they are very useful. Okay, of course, in selective cases, but just one thing. This is something I recommend, but we don't have evidence. We don't have studies. We have little amount of evidence on that. We can select in vast majority of the clinical studies on zygomatic implants. You can find a small population of patients, that have been treated on this way. Chantal Malaves did a paper on that, but she didn't publish. I don't know why. But the evidence is low. But my recommendation is to do that, to go for immediate loading if you have primary stability, and to place the prosthesis with no loading at all, no functional load, and to use tripodization. You need at least 2 and 3 anchorage. This is fundamental. Carlos knows about tilted implants, and in tilted implants, we follow more or less the same principles. So tripodization and immediate loading if we have primary stability and with no functional loading. But my feeling is that, in the future, more and more people are going to use this modality of treatment.
Okay,
we need clinical studies as well.
Let me suggest that we move to the next speaker. Lesley, well, keep your question for the closing session at the end, and also Dr. Kishinovsky's question that is pending. So I will share the question with you, and Lesley, please share the question with us right after Dr. Carlos Aparicio's presentation and corresponding questions. So I would say you do not need any introduction, and I thought I wouldn't do any. So Carlos, please move forward with your presentation on the ZAGA concept. And I think we all know about ZAGA. We created the ZAGA Centers network, the philosophy, the book, the papers. But I think a good refresher and an update from you on this topic is very welcome. So please take the video and the sound, and we'll be back live for the Q&A session right after.
Dear colleagues, dear friends, it is an honor and a pleasure to be here today to share with you the results, the publication, our last publication of the ZAGA Centers. I would say not only the last, but the first publication that we've done in the community, which is what makes me so happy. The title is Identification of the Pathway, an appropriate use of 4 zygomatic implants in the atrophic maxilla, a cross-sectional study. The outline is going to be very easy, so we will introduce the cross-sectional study, materials and methods, results and conclusions as a normal publication. It is going to be a nice excuse for me to, inside the materials and methods, review again what are our goals, what are our main goals for our minimally invasive osteotomy protocols. So let's go into it, because you will enjoy it for sure. As I said, this is our first collaborative paper, scientific paper, and I'm very proud of it for that. You see the list of authors collaborating in the paper, and this is the paper is already been admitted at YOMI, so it's good. The purpose of this cross-sectional study is to identify and characterize the pathway for appropriate placement of 4 zygomatic implants in the treatment of the severe atrophic maxilla. Also, the second purpose of this paper was to analyze possible anatomical variations on this implant path, especially when compare the anterior with the posterior zygomatic implant on the quad situation. As a materials and methods, we use, this is a computerized images of patients presenting indications for the use of zygomatic implants. In this case, for the use of 4 zygomatic implants to withstand a maxillary rehabilitation. We took cross-sectional planes of every patient. So we designed the proposed implant path, the ideal implant path, according to the Saga concept. And we analyzed the relationship of the implant osteotomy trajectory with the residual alveolar bone, or even the nasal bone in the anterior position, sinus cavities, maxillary wall, and zygomatic bone anatomies. So everything was studied and analyzed and compared one to the other. Regarding inclusion criteria, was the same as in the clinical situation. We were looking forward to have anatomy showing less than 5 millimeters height bone in the anterior and posterior positions, because this is a quad situation. And the patients were recruited, in order to have a global study, were recruited at centers belonging to the ZAGA Centers network. So we have some patients from all over the world, including China, Japan, Germany, etc. Just to remind you, what are the goals of the Zygoma anatomy guided approach? So the Saga osteotomy has the next goals. First of all, we like to achieve maximal primary implant stability. Optimize implant stability, primary stability, that's the first goal. We like to anchor our implant so hard. After this, we like that the emergency of this implant would be on the crest. So we like to have a prosthetically driven implant trajectory, placing the implant head at the optimal dental position. Then we like to preserve as much bone as possible, not only there at the alveolar crest, but also at the maxillary wall and of course at the zygomatic wall. Minimize invasive osteotomy. Then we like to maximize the bone to implant contact. BIC must be maximum. We like to have close contact of the implant with this bone and of course with the maxillary wall, but not only at the anchor zone but also here at the alveolar zone in order to better distribute the masticatory forces. We like also to completely seal the osteotomy with the right implant design. We like to protect sinus integrity at the implant head level, especially in those extramaxillary place implants. So, especially in this zygomatic implant critical zone, when we have to go for an extramaxillary implant path, this sinus lining must be protected. And we like also to prevent soft tissue dehiscency by digging the implant as much as possible and by using the right implant design. So at this moment you are familiar with the two main types of osteotomy. This is the channel osteotomy and the tunnel osteotomy. The channel osteotomy must be or can be more or less deep, and also the tunnel osteotomy can be totally and perfectly performed when the roof also is perfect, but can be also called tunnel osteotomy when the diameter of the osteotomy is bigger than the upper part section. Let's go for some examples and you will understand better. Inside the material or method, the Saga concept says that whenever you find enough bone here, alveolar bone, so whenever we have more than 4 millimeters height or 6 millimeters and 6 millimeters wide, we should go in an intrasinusal path like this. And no matter what is the shape of the maxillary wall, no matter if this is concave, you go through. No matter if it is straight, you go through. And you go through, and because you will reach implant stability at the anchor zone, this implant is going to be osseointegrated and will be able to withstand sealing of the sinus, so we will prevent sinus oral communication on the long run. Of course, when we use this kind of round osteotomy, tunnel osteotomy, we use a round implant section design. And you maybe understand better with this example. So this is the patient and the clinical image from where we are planning. So we find that this is about 5 millimeters, 4 millimeters, and this is like 7 millimeters wide. So we go through, this is our election, we go through this bone, and then since we are going to stabilize this implant on the anchor zone, we are sure that those 4 millimeters will be enough to first obtain osseointegration, and secondly to maintain it on the long run, escaping or preventing communication. So this is the same patient. We plan like this. We perform our osteotomy in that way. You see, we are not even opening any window because we don't need to spoil to discard bone. So this is the osteotomy for the second premolar implant. You see the osteotomy has been performed and the implant is in place, and 1 year after, this nice result is obtained. The sinus is totally transparent and the implant is stable, and this amount of bone will provide us with long-term sealing. You see another detail of a different patient, 4.4 millimeters high. So we go through as elastic. We go like this. We don't open any window. We don't discard any bone. Why? What's the meaning of discarding bone? and we place the implant, and this is the nice result over more than 1 year. This applies also in Saga type 3 situations where we have a triangle of alveolar bone like this, and the maxillary bone, the maxillary wall is very concave. But no matter how concave it is, we go through this alveolar bone, we preserve as much bone as we can buccally in order to provide the soft tissue fibers a place to attach to and to prevent soft tissue dehiscency with time. And this is the image 1 or 2 years after. So it's a very stable situation. Whenever we don't find this amount of bone, you know that the Saga concept says or recommends to shift the osteotomy to the buccal side. So our implant is going to be located buccally, externally in an extrasinusal or partially extrasinusal path, as you may see here. We try then to keep in mind two main requirements. The first one is to maintain sinus integrity at the zygomatic implant critical zone. And the second is to place the antrostomy, the place where our drill gets into the antrum, as far as possible from the zygomatic implant critical zone. Remember that. And this is the opposite to the previous situation of the tunnel osteotomy. So as you may see here, this is our channel osteotomy, and we are placing the osteotomy very far away from the zygomatic implant critical zone. As you may remember also, the Saga concept says that in the case we are placing an implant following an extramaxillary path, we have to leave a minimum amount of 3 millimeters thick bone from the buccal side at the zygoma, because we don't like to experience zygoma cracks at the level. So please leave some bone over here. And the point of the zygomatic entrance will be choose in relationship with this curvature. The flatter it is, the more closer to the zygomatic implant zone will be the entrance. The more curvature, the further we can place this zygomatic entrance. So this is, as a resume, you may see a totally tunnel here, partial tunnel over there, because we started with a tunnel, we follow with a tunnel, and then finally it cracked. So, bad luck, but still it's a tunnel because this diameter is bigger than the upright diameter. And two channel osteotomies on the lower part. And this is almost the same, partial tunnel on the upper and channels more or less deeper channels on the lower implants, on the posterior implant. Regarding results, we were able to examine 122 globally recruited patients. 488 zygomatic implants were analyzed. Out of them, the half were anterior, that is, the starting point was on the canine or lateral zone, and 244 were classified as a posterior, having the starting point on the posterior premolar molar areas. The anterior anatomy was classified on anterior implants on some percentages, and so was the posterior anatomy. I'm not going to bore you with the exact figures because I don't think they are too much important. As you may see, classified as A and P, A of anterior, anterior type 0, anterior type 1, anterior type 2. What in resume, what we saw is that anterior implants were half of them more or less classified as a Saga type A3. And regarding posterior implants, most of them were classified as a Saga type 4, just by curiosity. Of course, we again find a very marked 70% of asymmetric differences between the patients. So 70% of the patients have differences between the right and left anatomies. And as a conclusion, we were able to characterize the topographic implant pathway of those situations. We were able to understand that the trajectory of the zygomatic implants follow different pathways, if it is the case between the anterior and posterior implants. So the situation is a little bit different. For instance, we have the nose. We have to place the implant below the nose in some cases. And of course, we conclude the adaptation of surgical procedures and implant sections designs to individual patients' anatomic characteristics is essential to reduce early and long-term complications. And with this, I thank you, all of you, for being here today. And again, I'd like to point out that it is a landmark, really a landmark, to be able to collaborate between us for this first collaborative paper, for this first collaborative scientific work of the ZAGA Centers network. Thank you.
Thank you, Dr. Aparicio, for this very complete presentation overview of this publication. It is clearly a step forward using, I have sound back. Ruben, can you please mute? Yes, thank you. It is clearly a step forward, going a bit further than adapting the implant path to the patient, but in this case also the implant type, either the flat or the round ZAGA implants. And I'd like to hear the thoughts of Dr. David, Professor Chow, Dr. Davo on this step to go a bit further into personalizing the treatment to each patient. So before we used to personalize the implant path, and now we're looking into different implant types. What are your thoughts on this?
Is it a question for me, or is a...
It is a question for the other speakers.
Okay, that's what I understood. That's what I understood.
Well, I will start. I think it's a proposal. It's a good proposal because, you know, the problem in this field is that everybody is doing what they decided. So afterwards, we cannot compare results. This is a big problem. That's why maybe in 20 years we will go on talking about the same thing. So it could be a proposal. It could be a proposal. It's a biological study. Carlos did a big job analyzing this scanner. So it is, I repeat, a good proposal, and we have to check, you know, the reality, how it is working. And I think the great value can be in to try to homogenize the ways of placement, because this is the only way to compare afterwards the results. I have this problem with the other rules in my study I have been talking about, because sometimes they decided to use grafts and to use the fat tissue. So in some results, I think, I'm totally, well, almost sure that the problem was by the graft, not by the zygomatic implant. But I cannot say that because you are fixing a bias inside the clinical study. So if we homogenize the way of placement of implants, it could be useful to compare afterwards the results. This is my opinion.
Yeah. If you allow me, David, I will add something to Ruben's comments. I fully agree with you, Ruben. I fully agree. The thing is that we only can compare apples with apples. We cannot compare apples with cherries. So in this way, we have lost almost all the references. The only, I mean, years ago, we did a study on this procedure, and this is why we are proposing it now. In this study, we were comparing our 10-year results with the original Brannemar. I don't want to say implant, I would say fixture, in order to show my respect for him. We were using the original Brannemar fixture. As you remember, not for you, but for the audience, it was a fixture that turned surface grade 2 surface, titanium grade 2 surface with threaded all the surface. And so we compare the results we got on this group of patients that were followed at least 10 years with a group of 84, I think more or less 84 patients treated with the Saga protocol, but with the same implant design. So the first original Brannemar fixture. So, and by doing this comparison, using the same implant but different technique, we were able to start with this kind of protocol, I would say. And this, you are right, totally right. So we are proposing to unify and then to compare. So if we change many parameters, so we change the implant and we change the surgical way and we change the several parameters, we cannot compare anything. So let's try to do it in a more ordered way and then look at the results we get. And if we want to change something, just change one thing in an ordered way, and then you can compare. Otherwise, there are many variables. Is the final result would see like the typical meeting of implantologists. I do that, it goes well for me. I do that, it goes well for me. So, and as you pointed out, Lesley, weeks ago, so we have to be in order in a more scientific way in order to compare our data, in order to progress, in order to end up being better surgeons, better health providers.
We have received a question from the audience. Professor Chow, you want to add something?
Yeah, I have a question for you, Carlos. I remember I asked you about this, how to apply the Saga classification for the anterior zygomatic implants previously. And now I look at your figures, and it is interesting to see because the distribution of these different classifications is quite obvious. Because in the anterior zygomatic implant, type 4, there's 17%, whilst in the posterior, we have 57%. And now we have this round and the flat design. And I suppose the flat design is mainly for the type 4, So I'm interested to know how often you use the flat in the anterior region. The Saga flat implant.
Okay.
How often? Okay. How often you use it? You use it in the anterior region, because I mean, I look at your cases. Most of the times, when it comes to anterior, you are actually using the round more often. But still, I mean, we have 17% of patients they belong to type 4.
Thank you for the question, James. It's a very interesting question and a question that comes from an expert also. I think to answer this question, I need you to imagine the shape, the section of the flat of the Saga flat implant. So it is round, and then one of the surface is totally flat. So this means that it needs an orientation. So usually when you place the Saga flat implant in a posterior zone, like a second premolar, first molar zone, or even the second molar as you do sometimes, you probably will be able to orient the flat section to the soft tissue. Okay, but when it comes to the anterior, in order to get a nice emergency for the prosthetic screw, it is very uncommon that the flat surface to the soft tissue and at the same time to have the prosthetic screw well oriented. Hopefully I do express myself. So now we are working in an angle abutment in order to correct this angulation. At the moment I have this angle abutment, I will probably use more flat Saga flat implant designs on the anterior, as you have perfectly observed.
Yeah, I asked this question because I mean, when we concern about buccal dehiscence, I mean, it happened for the posterior and also the anterior implant. So if we can have flat implants that can be used in the anterior region, I mean, it improves also.
Totally agree with you, James. We can get dehiscencies in the posterior and also in the anterior. I will add something to these observations you made. Some of the tunnel osteotomy I did were like incomplete tunnel. So meaning that the distance between the two borders of the alveolar zone was lower than the diameter of the implant. So it was like almost a tunnel. This is why in this presentation, I have introduced a new drawing with this top of, like intermittent top of the tunnel osteotomy. But you're right. If possible, use a flat design in this because you get less risk for this. I'm not saying that the use of a flat implant section is going to prevent the soft tissue dehiscency. I'm saying that it's going to help you to avoid this. So it's not a guarantee. You have to make a nice osteotomy. You have to embed your implant, as Lesley said. You have to use all the tools you have. The osteotomy should be the correct. You have to start your incision giving as much as possible keratinized tissue on the buccal side. I would say is an ensemble of actions we should use, and the implant itself is one of them. It's not the guarantee. So is the implant, is the osteotomy, and is to have the patience enough to wait for the soft tissue to be healed previous to our surgery. Sometimes the patient wants to extract it and to place the implants, and we are risking a soft tissue dehiscency afterwards. So I prefer to wait for 3 months and then have a nice soft tissue, and then I start my surgery. I start cutting them. Yeah.
Okay,
yes.
I gathered,
Thank you.
I gathered 4 questions from the audience, and we have 4 speakers. So I'll tell you the first question, you pick it up, and the last question will have the hardest, by the way. The first question from Dr. Umberto Zanetti. In order to better cover the buccal part of the implant, do you use a local flap from palatal mucosa? Who takes this question?
I think I have published on this, and then I will be the last one, okay?
Yes,
yes. Okay.
But the most important, yes, but as Carlos said, there are many factors, not only this. The most important for me is not to be very bulky with the implant. The implant cannot modify the anatomy. If the implant modifies the anatomy, you can have a distance, a recession, even if you use graft or whatever. What we do, I know that Lesley does that, and I think that Carlos as well, is to make the flap from the palate to cover, you know, at least 1 centimeter of palatal mucosa must be covering the implants, but the implants cannot modify the anatomy at all. And even don't modifying that without modifying the anatomy too much, sometimes we have recessions and we have the problems. It's a sort of unpredictable. But yes, I do that, and I think that they all do that.
Okay, I will jump to the second question. Sometimes at the posterior zone of the maxilla, we have big holes due to lifting failures. How do you treat these cases if you're going to put a zygomatic implant there?
I can.
It's possible. It is impossible to treat this, but you have to leave it like that, and to take to be very, very, very careful with the soft tissues. You know, you are going to find holes in all these patients. It is, you know, if you have just 1-2 millimeters of bone, many times you have oral-anal communications in different levels. The most important is the soft tissues should be very thick at this level, and to manage this area very, very carefully. I have many patients with a bone oral communication, but we know oral communication because of the soft tissues. This is my opinion.
Yeah, I was just going to say, I mean, preoperatively, I think you pick that up on your CT scan. And then when you go to surgery and you make the incision just sort of above the area where there's a communication, you really have to be cognizant, because sometimes you can't avoid it. There's a hole and the sinus is right there. I think you really have to be thinking, I don't want to make my incision too deep, and it almost has to be basically a split thickness incision right over the area of the communication. So then you preserve the soft tissue over that communication and then deal with it from there. So it's really, you have to be mindful of that with that first cut.
Okay, we have 2 more questions. One from Dr. Said Yilmaz that he wants to know the results of the study club before it happens. So he asks about your opinion on using the buccal fat pad. What do you think about closing implants vestibular aspect with buccal fat pad and any complication related with fat tissue?
Carlos, you want to take it? You use it most with your scarf technique, right?
Yeah, I'm more fan of connective tissue than the fat pad. Because, but to be honest, I have no experience. So I'm usually, I'm go forward the connective tissue. So what, but you said something very important. And I think Ruben too said the same thing. The soft tissue dehiscency starts when I take my scalpel. So this is the crucial moment. When I take my scalpel, I'm deciding the 50% of the possibilities of having soft tissue dehiscency. So this is the critical moment. So the more, first, as I say, we wait for having a nice mucosa, healed mucosa. And then we take our scalpel and we have to think first. Where is going to be my implant head? Where is going to be located the zygomatic implant critical zone? And I know that I should provide as much connective tissue as possible there. If the patient comes from a history of removable denture, I'm very relaxed. Why? Because I know that the patient wearing a denture for a long period of time usually has a thick soft tissue on the palate. So I'm very fan of splinting the soft tissue on the palate. If I need, I make a pediculate connective graft that I secure on, if possible, on the remaining alveolar bone and cover the implant neck. That's very, very predictable, very, very predictable. Connective tissue has information, genetic information for the gingiva, and it will protect your implant very well, providing, as Ruben and Lesley said, you are not modifying the profile. You are not going outside the bony envelope with your implant profile. But even when you are going a little bit, protruding a little bit, not too much, of course, this scar graft around the implant neck will protect you from soft tissue recession. Regarding the buccal fat pad, I have friends like Guy McLellan, and we have in this community the inventor of this technique, De Moraes, that are very fan of this, and hopefully they will show us their results, and they will teach us how to use it. But honestly, I'm not too much experience with that.
Okay, I have the last question, I think, for James, which is from Dr. Kishinovsky. He says, very little has been mentioned about guided zygoma placement. What are the thoughts of the authors on this topic?
I have been doing this for many years. I'm still doing this, but only in very selected cases, because doing guided surgery for zygomatic implant placement, at least we have two problems. The one problem is how to stabilize the surgical guide during surgery. It is more difficult than, more common cases when we have more bone support. Because if we are working on zygomatic implant, usually the bone is more limited. And especially if we are working on cord zygoma, and you can imagine the positioning of the guide, stabilization of the guide is a real challenge. And the other problem is when we are performing the drilling through the guide actually can only control the entry. And because we are using a very long drill, so the tip of the drill is not really very much controlled by the surgical guide. So we have a concern about the accuracy. That's why I developed a device in order to control the entry and also the tip of the drill during osteotomy. And I keep using I call this a Sagoma drill guide in some of my patients, but I have to admit, placing this drill guide during surgery and passing a long drill through the drill guide and the surgical guide is a difficult task. So I still don't do it routinely because it is not user-friendly, but it works in selected cases. Yeah, I still have, I have been doing this for many years. I'm still doing this on selected cases, as I said, yeah.
Okay, this is the end of the questions. I think we should be close to finishing this event soon, especially thinking about Professor Chow, that today is soon going to be tomorrow. And thank you for staying this late. Lesley, you can still stay the whole day, which is fantastic. So we can go on a few hours. We have really a global panel of experts. Thank you for taking the time to be with us, to share your knowledge, experience, advices, show the mistakes that you did so we don't make them, and share the progress. So from my side, big thank you. From Radu's side also, we also apologize to the participants for the sound issues and to the speakers. And I will let the final words for Carlos, if you want to close the event.
Oh, thank you. I don't think I deserve this honor because you did perfectly. First of all, I'd like to thank you, David, because I think you was born for this task. You did perfectly. Thank you. You've been able to help us, myself also, in a delicate moment. So thank you for this very smooth conduction of the event. Say that for sure I will thank all the participants on this, and I would like to say goodbye by pointing out that we are in a very, very good position, meaning that we are collaborating. The older I get, I believe more in collaboration. I think only intelligent people are able to collaborate. And by collaborating, we will go further and further and further. It is if I do my effort myself, then the effort ends in myself. If we do efforts together, we will not only add, but multiply. It's going to be exponential. So when you were talking, I was just not noticing new topics for the study club. There are so many things. It's a big, big field that opens in front of us, and this is the way to collaborate. This is what distinguishes an intelligent person that sorry for that, a stupid person. Only intelligent people is able to collaborate. Thank you for being here, everybody. Thank you.
Thank you.
Yeah. Thank you.
Thank you.
Thank you,
Have a
David.
good
so much.
Thank you, Carlos.
night.
Yeah.
Thank you all.
Thank you.
Radu, I will let you hit the button to finish the event.
It's a big honor, Radu. And thank you. Excuse me, I didn't say thank you to Radu also, because I'm in front of him. I've been seeing him suffering, stressing, but at the end he got it. Thank you, Radu, for that also. Thank you.
Thank you. Bye-bye.
Thank you.
Bye-bye.
Bye.
Thanks.
Bye-bye.
Bye-bye.